Thank you.
Confirming.
Yep, it looks like you've started. Thank you.
You're welcome.
All right, can you do those two motions?
As I mentioned earlier, we need to close the November meeting before we open the December meeting. So let's do it again, please. Can I have a motion?
I have a motion to close the meeting for November.
Thank you, Member Hammer, for seconding, and we're ready to open the December meeting.
Awesome. So yeah, our meeting continues to be held by WebEx, and this is pursuant to the governor's orders and mayoral proclamations that continue to suspend and modify the requirements for in-person meetings. And we're going to continue to convene remotely, and public comment will be available on each item, and each speaker will be allowed 3 minutes to speak. I'm going to take roll call now to establish quorum. Member Eisen is absent today. Member Fields?
Aye.
And Member Gonzalez is also absent. Member Hammer?
Here.
Chair Lassar?
Okay.
Member Lipton?
Here.
Member McWigan?
Present.
Vice Chair Patterson? Currently absent. Member Salinas?
Here.
Member Short? Currently absent. And Member Wong?
Present.
Cool. So we just skip by there with 7 out of 13 members present. We do have the quorum to continue, which is at least 7. And now going to excuse absent members. We have 2 rounds of this from last meeting and today's meeting. So we're first, because we didn't finish our excusal from November's meeting, did want to take roll call votes on excusing Vice Chair Patterson. Chair Lassar, any discussion before we vote on that round of excusal?
Thank you. I could not recall if we had heard from Vice Chair Patterson last time.
We did not.
Okay, and I know that we've reached out.
Yes, we have.
Okay, and I just did as well. So I guess I'm making the motion to have that as not excused.
And this is for the November meeting, Chair Lassar?
Correct.
Okay.
All right, so I'm going to now call roll call and ask each member to vote yes or no to excuse Vice Chair Patterson from November's meeting.
Excuse me, Chair Lassar, did you say not excuse or excuse? Not excuse.
To not excuse. So the roll call will be ask each member to vote yes or no in not excusing.
And yes, and I just want to clarify that this is only because I'm sure that there's a lot of extenuating circumstances and things are happening. It's just we need a full board to do this work.
Thanks, Chair Lassar. So again, members, you're going to vote yes if you are unexcusing.
Okay, and then I just got a text from Jamil. He's joining now for this meeting.
Okay. So we do have to vote on that November one. Member Fields?
Oh.
No. Member Hammer?
I'm voting yes on Chair Lassar's motion.
And Member Lipton?
Is a yes supportive of the chair's motion, or is it no support of the chair's motion?
Yes is supporting chair's motion.
Okay, yes.
Member McWigan?
Yes, I support the chair's motion, not excused.
And then Member Salinas?
I support the chair's motion.
And then Member Short, if they're on yet? Member Wong?
I support the chair motion.
All right, so we do have, I believe 5 yeses So we have majority vote to excuse, I guess, majority of the folks present. So that's 5 out of 7. We have majority vote to excuse the absent or the make the unexcusable. And we are now going to vote to excuse member Eisen, and currently we don't, so member Eisen and Gonzalez, who did let us know that they wouldn't be present today, and it looks like member Short, who currently is not here, but did not let us know that they.
Can I just say, I just texted Sarah and she says that she's out of town and that she did let you guys know.
Let me check. Thank you for saying that, Member Salinas.
Thank you, Member Salinas. And I think Member Vice Chair Patterson has joined us now.
Yes.
Wonderful. Yay. Great. Thank you.
Welcome, Vice Chair. So again, we're now doing this voting for December's meeting. We are deciding on whether we're asking each member to vote yes or no to excuse member Eisen, member Gonzalez, and member Short.
And we've heard from everyone.
We've heard, Jen is currently checking to see if we received any emails from member Short. So
Okay.
we will wait on that before we vote.
Okay, great. Yeah, I don't want to, otherwise we can just group it in two.
Yeah, I have in my records that she wrote for a doctor's appointment for the last one, but not for this one. And just in all honesty, it could be user error on my part that I missed something. So if she's saying that she wrote me, I think we should go with that.
Okay, so I make a motion to go ahead and approve the absences.
Great. Member Fields,
Yes.
member Hammer,
Yes.
Chair Lasar, you've said yes. Member Lipton,
Yes.
member McGuigan,
Yes.
Vice Chair Patterson,
Yes.
member Salinas,
Yes.
and member Wong.
Yes.
Great, so we have 8 yeses, we have majority vote. We'll now move on to meeting goals.
Great. Okay. And get where we are. So today we have the goals of reviewing the progress of the analytics and evaluation team's work on MHSF key metrics. We have the goal of being apprised of staffing and wage analysis study progress, and an update on the stage of design for the Mental Health SF Service Center, and to provide input for the December implementation reports. Please remember that we've turned off the chat function, and due to making accessibility for the public, please take bio breaks as needed. And we do have a bio break scheduled, but please do take care of yourself. We do need a quorum to move forward. So when you're not present, please do go off camera so that we know that you're not here. And when you're back, please come back on to the camera. I think, are we at next slide? Yep. Or not yet? Okay, great. So a reminder of what we're here to accomplish. The charge of this work group is to advise on the design outcomes and effectiveness of mental health SF to ensure its successful implementation of the ordinance domains. Today, we have speakers whom we have heard from before who are directly engaged in designing and implementing this MHSF domain. Dr. Hillary Cunnins, our Mental Health SF Director, Dr. Monica Rose for Analytics and Evaluation, Wendy Lee, Glenna Stars, Kat Benson for Staffing and Wage Analysis, Dr. David Pating, Kelly Fitzpatrick, and Yunjun Kim for the Mental Health SF, Mental Health Service Center. So next slide. Please move on to, we are now moving to discussion item number 1 related to the remote meetings. And I pass that back to you, Ms. James. Thank you.
Yeah. Yes, so we're familiar with this as authorized by California Government Code 54953E and the mayor's 45th supplement to her February 25th, 2020 emergency proclamation. This meeting will be held remotely without providing a physical location. The state requires that we submit what they refer to as findings every month. These findings are that the IWG as a public body has reviewed the teleconferencing meeting status in relation to the COVID state of emergency. The formal requirements titled Resolution Making Findings for Teleconference Meetings are posted to the IWG's website. By state requirement, we must review and record our findings every 30 days. So I'm going to read those two key resolutions and then we're going to vote on them. So 2 key resolutions on the slide are: 1, the state of California and the city remain in a state of emergency due to the COVID-19 pandemic. At this meeting, the IWG has considered the circumstances of the state of emergency. And 2, as described above, because of the COVID-19 pandemic, conducting meetings of this body and its discussion groups in person would present imminent risks to the safety of attendees, and the state of emergency continues to directly impact the ability of members to meet safely in person. Any questions to the resolution, its purpose, or the findings? All right, well, Chair Lassar, are you ready to open the floor to public comment?
Yes, please. Ms. Sadka, please take public comment.
Sure will. So the number remains the same for meetings 415-655-0001. You'll enter access code 2488-316-2188 for today's meeting. Specifically for this meeting, because we are using a webinar platform, there will be a password required. That is 1234, and then you'd press pound and then dial *3 to line up to speak. I'm going to see if there are any callers. Currently, no callers in the queue. For the sake of time, I'm going to close public comment so we can get rolling. All right, so we are now voting on this. Again, we're approving meeting minutes for November. Can I get a motion to approve? Or we're sorry, the remote findings.
So motion made to approve the findings.
Second.
Awesome. Cool. So member Fields, yes or no?
Yes.
Member Hammer,
Yes.
Chair Lassar,
Aye.
member Lipton,
Yes.
member McGuigan,
Yes.
Vice Chair Patterson, Vice Chair Patterson, yes or no on
Yes.
the approval? Awesome.
Yeah.
And then member Salinas
Yes.
and member Wong.
Yes.
Cool. We have 8 yeses. We're going to approve that, and then we are now last rounds of approvals, meeting minutes. Yeah.
We will now move on to discussion item number 2, approval of the meeting minutes. These minutes are posted on the IWG website. Are there any changes to the minutes as posted on the IWG website? I'm not seeing any hands. Ms. Sadka, please open public comment.
Cool. Public comment on this item 415-655-0001, access code 2488-316-2188. Password for today 1234. Then you'd press pound and then you dial *3 to line up to speak. Do we have any callers? Currently, no callers in the queue. Because there are no callers in the queue, I'm going to close public comment. We are now going to vote on these minutes from November. Member Fields. Or before that, can I get a motion to approve?
Motion to approve.
Member
Second,
Hammer? Who seconded it?
Lipton.
Thank you. I will now call roll call. Member Fields? Member Fields? I will go back to you, Member Hammer.
Approve.
Chair Lassar?
Aye.
Member Lipton?
Aye.
Member McGuigan?
Yes.
Vice Chair Patterson?
Aye.
Member Salinas?
Yes.
Member Wong?
Approve.
And Member Fields?
Yes.
Great. We have 8 yeses, 0 nos. We have majority vote to approve the November meeting minutes. All right, on to the next discussion item.
Thank you so much. So we are now moving on to discussion item number 4. You'll be hearing from Dr. Hillary Cummins and Dr. Monica Rose on the mental health SF analytics and evaluation team. I'm very excited for this conversation, and I think now I turn it over to you all.
Morning, everyone. Can you hear me?
We
Yes.
can.
yes.
Good morning.
Morning. Hi, all. So I will be presenting to provide some updates on our key performance indicators. I'm joined, as you heard already, by Dr. Monica Rose, Dr. Angelica Almeida, who will be joining me to discuss some of our updates. Next slide. Okay, I said that already. Next slide. Okay, so I'm going to start just by reminding you all, I think that some of the newer members may not have actually seen this slide, which we showed now, I think, many, many months ago. So just as a reminder for all of us, the mental health SF key population was defined in the mental health legislation as follows. The primary focus of mental health SF is to help people with serious mental illness and/or substance use disorders who are experiencing homelessness get off the street and into treatment. And that is a quote. So to begin our work, but here updated as of August, we looked at 2 data sources that included our DPH electronic health record system, as well as data from our Department of Homelessness and Supportive Housing to understand who and how big the population we are aiming to reach is. So using these data, we estimate, again, and this is a little bit different than, just for your awareness, the point in time estimates, which are published by the Department of Homelessness and Supportive Housing, number about 19,000. Of those, we identify that approximately 8,700 have a serious mental illness and/or substance use disorder. In that smaller circle of about 8,700, you can see that the further breakdown by diagnosis, about 51% of those folks have a serious mental illness, and about 84% of them have a substance use disorder. About a third have both a serious mental illness and a substance use disorder. Next slide. Also, something that you've seen a while back now is the 11 core metrics or key performance indicators that we are aiming to share regularly with both this group and publicly. And I know there's been conversation over the last couple of months about what we ought to be measuring and how we might measure it. And so just for everyone's kind of level setting for a moment, it's taken us some time, I realize, to get to the point where we can begin to share metrics and are working our way through in the coming months to be able to present baselines of each of these 11 metrics to all of you, with the 11th being hardest to measure, that is quality of life. And I'll reflect, if I may, both member fields feedback as well as others, that this is really quality of life and functioning, sometimes called recovery. It is really sort of our, I don't know if this is the right term, but like holy grail. We want people to be in community with high levels of functioning, be integrated and independent. That is a journey in terms of what our health system records and how it records it. And so I just want to invite everyone to bear with us as we are building out systems and so forth. So what I'm excited to do today is share with you our first baseline look at core metric number 5, whose goal is to decrease wait times for intensive care management services. Core metric number 7, naloxone distributed in the community. 9, decrease the number of overdose deaths due to overdose, and 10, decrease disparity rates in deaths due to overdose. What I hope to be able to share with you in the coming months is we will fill out and you will know each of these metrics where we're starting, and then be able to report out on them in sort of sensible intervals. Next slide. So again, I know many of you, we have talked about intensive case management, and many of you are super duper familiar, and probably some of you are less familiar. So intensive case management programs provide intensive outpatient behavioral health treatment for people with the most complex mental health and substance use disorders. Though the nomenclature is a little bit confusing, I just want to acknowledge it is both treatment with really tightly wrapped around case management and multidisciplinary teams providing care. Clients eligible for ICM, as we call it, must have a mental health diagnosis causing significant functional impairments or symptoms, as well as imminent risk of, as we say, decompensation worsening without treatment. They must meet one of several additional qualifying categories, and the specifics are there. The services provided by ICM can include behavioral health treatments, that means medication and or counseling, or both, crisis intervention, case management, as I've already described, field-based services, meaning not just delivered in a brick and mortar place, but really out where the person is, peer-based, peer-delivered services, tight linkage to social services, and tight linkage incorporation of family supports. Next slide. So right now in the city, we have 14 ICM programs that serve adults. These programs include, and we're sort of doing a bit of lumping here, something called full service partnership programs, which are funded in part or exclusively by the Mental Health Services Act of the state. The full service partnership programs allow for support financially, not some services that are not billable to Medi-Cal. There are tailored ICM programs for transitional age youth, older adults, and justice involved folks. There is an approximate average census of about 1,000 enrolled in ICM, and about 177 new clients began ICM treatment in the last fiscal year. What this enumeration does not include is a number of what we call linkage programs, that is clients or people who need an intensive level of care and are delivered in an kind of ICM level of care, but one that is meant to be transitional, either to ongoing ICM care or stabilized into sort of regular outpatient care. Next slide. So our main finding is that in fiscal year 21-22, that is, that ended June of 2022, 177 new clients began receiving ICM treatment. Their median wait time was 35 days. We defined wait time as beginning as the day a client's referral is received by the ICM program managers and ends the day a client's ICM treatment episode starts. Of note, more than half of people who waited for more than 10 business days for ICM services did receive at least one routine healthcare service while on the wait list. Noting that this is not 100% because this is precisely why folks are getting referred to ICM, which is that they are eligible for and they need a higher level of care in order to be engaged with that care. Next slide. I want to now share our analysis by some of our key demographic and social determinant factors. And this is the first of several different slides.
Dr. Kunins, do you want us to hold all of our questions till the end? Is that best?
Why don't we do, is that okay? And
Yeah,
then,
that's fine. I just need to make a note. Yep.
yes, thank you. Thanks, Chair Lassar. So if folks could hold their questions, that'd be great. And we have, I believe, till 10:25 on our agenda. So we have a lot of time, and I just have probably about 4 more slides. So we're close. Oh, no, we have, you know what, maybe I'll pause after ICM wait time. I'm sort of thinking on my feet, and then we'll turn to overdose and naloxone, but maybe I'll just get through another couple if that's okay. I don't see that many of you, so I hope that's okay. So first, you're having a look at the median wait days stratified by housing status. And so what you can see on the bottom part of the slide in the small table, and you'll see that this is the same pattern as we go. There is a new client count of 110 experiencing homelessness and 67 who were housed. Of those folks, persons experiencing homelessness had a median wait days of 29. People who were housed had a median wait days of 58. Next slide. Same pattern, some kind of analysis but stratified by age. So as you can see, again, I'm going bottom to top. There were 126 adults aged 25 to 64. That's a broad age category who entered treatment, entered ICM, 28 older adults and 23 transitional aged adults. Older adults had the longest median wait days of 49, adults a median wait days of 40, and transitional age youth of 28. Next slide. In terms of gender, we had, I should just acknowledge that we aim to categorize male, female, trans male, gender queer, gender non-binary. Some of those cells are very small, and so we do what's called censoring those small cells in order, because the estimates then are unstable. So what you can see is that males had a longer wait time of 62 days compared to females with a wait time of 12. Next slide. I think we have one more slide. Oh, 2 more slides. By primary language, we the primary language of folks coming in was 160 people with a primary language of English, 17 people with a primary language of other than English. People with primary language other than English had a median wait days of 22, and people with primary language of English had a median wait day of 36. I just want to note that I am sort of very deliberately in making these comparisons, not saying quantifying a lot, a little. Some of these groups are very small, and one of the kinds of tests that we might choose to do is statistical testing to understand if they are statistically different. And so because some of these numbers are so small, we are kind of refraining, and I have one more slide, from saying like, we know that they're meaningfully different or not. So we can talk about that as we in the discussion as well. I know that folks will have questions, and I'll need some help from the analyst folks to say that better. Next slide. And then finally, we examined median ICM wait days by race and ethnicity, and sort of similar to what I just said about gender, we collected folks' self-reported race, whether Black, African American, there were 60 clients, whites, 55 clients, Hispanic or Latino, Latina, Latinx, 29 clients, Asian, 13 clients. And then you can see the other categories all had fewer than 10 reported clients. And so we did not calculate their median wait days. You can see that white people who identified as white had the longest wait times, followed by Asian, with lower wait times experienced by Black, African Americans, and Hispanic, Latino, Latina. Next slide. So we do have been working to and have additional plans to reduce wait times for ICM level of care. Prop C funding and MHSF planning, as you all know through this group, we have made and will be making additional investments to increase program capacity. In the past year, we have added $200,000 to existing contracts to enhance their staffing to be able to accommodate more clients. And we have a forthcoming request for proposals that ought to be released in January 2023 to further increase ICM capacity. We have also been engaged in a variety of practice improvements to reduce wait time, including stepping down patients who are ready for potentially lower levels of care, as well as you have heard from us, adding resources to outpatient services to improve retention and stabilization so that people either don't need higher levels of care or are become better established in outpatient care once exiting ICM. And I think that's the last ICM slide. Yeah.
Okay, great.
Okay, so let me pause there, and maybe I can invite Doctors
you.
Alameda and Rose to pop on as well if they are here.
Beautiful. We have Member Fields, Member Salinas, and I have about 3 questions myself. Let's go ahead. Member Fields.
Thank you. Good morning. Thank you, Dr. Cunnins. I just have a question on the very first slide where it mentioned some of the functions of the ICM system, and it refers to a linkage to social services, but it doesn't mention linkage to community-based treatment. Is that because there's an assumption that ICM will do all this by themselves, or is there an intent to link to community-based treatment services as well as social services, because it's not listed among the bullet points?
Thanks, Member Fields, for that question. So this is where I sort of started at the top. I intended to communicate that ICM is kind of a nomenclature challenge. It is treatment. And some of the ICM programs are actually operated by community-based treatment providers. So does that answer your question?
Well, no, say in a particular instance, someone's in ICM, they don't take people home with them at night. It's not a 24-hour service. If someone is using and in ICM, is there an intent to use that relationship to link to treatment for stabilization and then continue in the ICM program? In other words, is this a parallel to community treatment, or is it also meant to identify when people may need more support than a case management model can provide, no matter how intensive it is?
So the way I think about it is this is a level of treatment. If people need a higher level of treatment, it sounds like what you're saying by community-based treatment, you mean residential treatment. I think that's what you're saying.
Well,
meaning they would,
yeah,
I think so, meaning, so if they need to step up to a higher level of care, yes, that is that is part of what they ought to do. Meaning if somebody cannot be stable or stabilized in ICM level of care, stepping up to residential level of care is absolutely, and including if a hospitalization is needed.
okay.
Does
All
that
right.
make sense?
Yeah, I appreciate
think
that.
I just also want to acknowledge I come from anyway, ICM, I think ICM, the term, as my staff know, I sort of took me sort of as I was settling in here a long time to really understand this. Though it is called case management, it is really wraparound case management and treatment, or intended to be that. And so we should be thinking about ICM as a level of care and treatment that includes case management, not it, but it is very much an integrated model here of case management plus treatment. So just for everyone's clarity, and I think of it as a level of care kind of in between residential treatment and outpatient kind of clinic treatment.
Yeah, that's helpful. Thank you.
Thank you, Member Fields. Member Salinas?
Hi, good morning. I also just want to echo that ICM is most definitely treatment. So we have very highly skilled clinicians, psychiatrists, nurses, day program that, has been a bit compromised by COVID, but yes, we are very much treatment and link folks to from here. I mean, we are the thread to everything for our clients. So, and that definitely includes residential treatment when they can and will participate in it, and hospitalization and LSAT. If that's what it is. But of course, yes, we have to close people when they go to LSAT. I have some questions about the wait list data. So I guess I want to clarify, I believe you said so with page 19 on our PowerPoint that these 14 programs do not include the linkage programs, right? The rapid response teams, they do not.
That's right. And just if member sleeves, can I just make a small language correction, if I may? This is wait time data and not wait list data. And we can talk about some of the decision making there, but this is, again, I just want to reiterate, among people who start ICM treatment, how long did they wait to get it? Does that and I don't know if you were, anyway, we can circle back to that. This may be too in the weeds.
Yeah, okay. So this is from the time we get their referral, right, to when they actually get linked to a case manager, correct?
Yeah, let me, Dr. Rose, is that?
Yeah, that's correct. So it's from the time that we receive the referral to when they actually get their treatment episode open and begin care.
And so I guess I'm just perplexed, and so then maybe it's about wondering how this differs by program. If you guys calculated that data, because between our citywide programs, just between our focus program and our forensics program, that's at least about 645 clients, right? So we're well over half in those two programs of the wait list, and our wait times are just so much higher than so it would almost seem as though other programs are having a wait list of less than a day, if you calculate that people are waiting in the forensics program 6 months, in our program 8-10 months, so when you arrive at 35, I wonder if you have breakdowns of per program. And so then just wondering how are then we distributing referrals, and why is it working that way? Because in some in some ways, I think we provide very excellent care, and I think that probably lots of people are specifically, right, referrals are specifically requesting Save Focus, and of course, the forensics program is very specific, right? So it seems as though if an individual gets referred to the Focus program, they're waiting, 9 months when they could have been referred to another program and gotten care in less, in 2 days or something. So I'm wondering how
So let me say a couple of things. First of all, this, you're asking this suggests, and you are seeing, just want to say the IWG is seeing the first look at these data, and we are very grateful for feedback. And I knew, Member Salinas, you would have extremely thoughtful things to say. I just want to say that. So we didn't want to present by program. We didn't think that was appropriate for this audience. We are happy, and I think you're raising important questions to come validate the data with, and we'll talk to the team, and we'll talk to you as well as other folks coming from ICM programs about how we can best validate these data. Let me just say that we made an analytic decision, and I will be curious about your feedback. For folks from linkage, we considered folks receiving linkage level of care as being in ICM level of care, and their wait time, if they were receiving care immediately, was 0. And so though they didn't necessarily end up in that linkage program forever, that is a transitional ICM level of care model that meant that they were receiving kind of definitive level of care right away. And I am very curious, and if you want to sort of digest that, and we can, happy to follow up after, if that feels valid. But that was an analytic decision we made.
So they are included then? The linkage programs are included, or they were not?
So the programs are not included as a ultimate where they land program. It's that if they were coming from a linkage program, we considered them to not have waited for care.
Yeah, because those programs, yeah, I mean, so I think it's interesting. I mean, so I guess, so then to clarify, linkage programs are added in this data. I thought that you had said they were not added. So I mean, that makes a lot more sense about why wait times are skewed then, given, I'm also wondering, I think we do a really good job of keeping those pre-admit, we keep that pre-admit data in Avatar, we enter it. So you can get pretty accurate wait time data from our programs at Citywide. I'm wondering, how are other folks keeping it? Are they doing as good of a job of entering everybody that's on their wait list into Avatar? So I'm wondering, is there discrepancies with how folks are reporting their wait list data, or keeping it? But I think overall, I guess maybe then it would be interesting then to separate out what it looks like if you take out the linkage and CCRT team data from the overall numbers, because they're waiting, right? They go directly to the hospital and pick somebody, start work with folks. And that's, and there's a lot to be said for that. I think when I used to work at the senior FSP, that was quite a while ago, when you can do that and start with someone from that point and then never have to transfer them, it's really great, Yeah.
And I see Monica just jumped in. Just one thing I do want to sort of put just a finer point, because I think you're alluding to also a decision we made. We did not look at and this will not be meaningful to everyone, I realize, we did not look at average wait times. We looked at median wait times. Why? Some of the outliers that you're alluding to, Member Salinas, when you look at averages, really kind of skew your findings one direction or another. If some people, for whatever reasons, wait, hopefully this is a never, but 150 days or something like that. Whereas if we look at medians, we tell you 50% of people waited at this amount of time or less. And so this is, again, sort of reasonable. It's a reasonably standard approach when there is data that's distributed in a very skewed way. But I think, Member Salinas, to your point, is all of you and us clinically may have, examples of, but I have a guy who waited da da da. And so is that included in the data? And the answer is yes. But by using medians, it really looks at where 50% of the people waited, and that's what is a reasonable measure that we determine with our analytic team. And I see Monica who can speak to that more clearly. But I think you were asking another question about data entry and sort of completeness of data entry. I think that's what you were importantly getting at. I'm wondering, Monica, if you have any, Dr. Rose, if you have any comments about that, sorry.
Oh, sure. So in terms of the end time of the wait time, we're not using the pre-admit, we're using the regular treatment episode. So that's, and I think that would be fairly consistent because that's needed for billing purposes. So I just wanted to clarify that, if that helps.
Member Salinas, do you have any other questions? I mean, I think frankly, these are really important pieces and you probably should get this data early so you can poke holes in it next time and ask all the questions ahead of time. But I want to make sure that you have any other questions. I know I have a few, and I also know we do need to keep it moving.
Yeah, I don't. I'm just concerned because I want to make sure that we really have accurate representation. If we're building,
Definitely.
we have, what we need to build up is, based on what's really happening on the ground, right? And that we're finding our clients are waiting so much longer than 35 days, and we're more than half the spots. And so just, want to make sure that that's clear so that resources are allocated where they need to be for this population.
Most definitely. Really great point. Dr. Cunnins or Dr. Rose, do you have any other responses for Member Salinas?
No, just to say this is, iterative. So I don't want, we're presenting this to you, this group, as feedback and really happy to take it. We worked, I just want to acknowledge how hard the team worked on this. We were excited to present to you and also know that we would get important feedback from this group.
Absolutely. I mean, this is what I call, as I always say to my students, critical feedback. It's in service of. It's not to criticize. It's to create a holistic and accurate representation. So really appreciate your work, and Dr. Rose, all of your work. It's incredible, and it's challenging. I know how challenging it is just to get data at one organization, let alone all the different streams that you have to engage to get all of this. So just want to say thank you for that. I have 3 questions. One, I'm just going to give them all to you now. One is the 35-day, and now I want to make sure, am I saying wait time is the correct term? I think it is. Do we have numbers on hospitalizations during that time? What I'm really looking at is what happens to people while they're waiting? That's one question. 2, why such a big difference between gender in the wait time? And then third is really, again, Black African American population makes up 34%, while only being less than 3% of the population. I mean, it's a staggering, really staggering disproportionality of people needing services. And so I cannot iterate enough the need for prevention early on. And there was a really good op-ed this morning in the New York Times that really focused on conversation around violence prevention, around the need for stronger, safer communities, which really iterates, I mean, obviously the trauma and the ongoing experiences of our community. So sitting out here specifically in Baby Hunters Point today and, every day at the office, and I've had over 16 homicides in one very close geographic neighborhood. So unless we can get a handle on the trauma and these other pieces, they're also related. I understand that we have to work in the system, but I really do need more focus on prevention. Unless we have prevention and services that help me ameliorate the everyday traumas that our community is facing, then we're going to keep having these staggering disparities. So I just wanted to make that point as well. I don't know that you can't wave a magic wand and make that number better, but it is staggering to me that 34% with less than 3% of population of overall people needing this intensive case management is really it's painful, very painful.
Yeah, I just want to echo what you said, which is I think I mean I agree totally, and I just want to also say that I understand this disproportionality as also products of systems of incarceration, involvement with the criminal legal system that sort of worsen trauma and worsen the sequelae. And so prevention is also out of the mental health system, I just want to say, and thinking about policies and alternative responses that I know you care about deeply, we care about deeply. I do want to mention as we move forward, we're sort of zooming in on ICM. I don't want this to feel like there's nothing else going on. I want to mention an intervention in particular that has been funded by the Mental Health Services Act that I believe we have discussed here, which is innovation of care, providing culturally congruent care to Black African Americans for mental health as, again, one of many strategies to prevent the need for, I would say, higher levels of care, to improve retention in care, to improve our ability to deliver effective care. And I know you in your day job are involved with that as well, but just for the larger group. And I know more can be said. I do think that just thinking about some of the large differences that we observe, we both about who's in the population as well as who is waiting for what amounts of time. I think this is where we do want to validate the data further with our providers, with the group, the colleagues who are delivering ICM care, and to understand what programmatic improvements are needed to reduce differences, and ultimately to decrease wait time overall as an overall objective. So just in conclusion for this section, and we have a couple more slides on overdose.
Oh, Dr. Prince, could you tell us about the hospitalizations or the
Oh, I'm so sorry. Is what happens for your first question?
Yeah, sorry.
So I'll sort of describe this as what happens while people are waiting. We did one look at, as I mentioned, the number of people, proportion of people who received other routine care. I think you're kind of flipping the question that I don't think we yet have the answer to what proportion had untoward events, whether I'll just even broaden it beyond hospitalization, whether they had an ED visit or another crisis visit, perhaps mobile crisis. So I think Dr. Rose, we don't have that, but we will bring that back to the team unless you tell me otherwise.
That's right. I think it's an excellent question because, when people are waiting for treatment, I think one of the most important things is connecting them to whatever treatment is available and to try to stabilize them while they're waiting. But no, we don't have the data right now. And I think it's really important data. If I could speak really quick too, because I love the question that you asked, Dr. Lasar, about why the differences in the wait times by gender. I just think that we're presenting the what right now. We're not presenting the why. And I think that that is a really critical question, not just for overall wait times, but for all of the demographic characteristics that we were looking at. That takes really a deep dive into looking at individual cases, looking through what happened, what were the barriers, what went wrong. And I think that's the most exciting part of the work, in my mind, and part of the, sort of the QI process of how do you improve the wait times. I think first we need to understand what's behind them and what contributes to any differences there might be by demographic factors. So a lot more to come about that.
Thank you so much.
Can I ask a question before we move on?
Yes, please. Member Lipton?
All right. I have a very quick question on the wait time, the average wait time of 35 days. If I understand correctly, that's an average over the course of fiscal 22.
Yes, it's a median wait time across all clients across the entire year.
Okay. And do you have any information as to whether that number was coming down or going up, or was it pretty much stable over the entire 12-month period?
There was some variability, but the numbers were pretty small by quarter.
Mhm.
And so it wasn't in a single direction. For this initial look, and this will be we will bring this back to the group, sort of elected to look at it across the whole year. But going forward, we are thinking to look at 6-month intervals to get at the question, hopefully, that we see going down, wait times going down as we are adding money and services to the programs. The other characteristic, in addition to sort of small numbers by quarter, as you all know, we saw a lot of impact on services from COVID, with staffing outages, with constraints. You heard from Member Salinas about their day program being constrained or closed because of COVID. So I think that was kind of our analytic decision at this baseline, anticipating, I think, where you're going, which is we want to look at it in smaller time intervals.
Yeah. No, I agree. And I was going to ask you whether the time frame is more, the waiting time is more demand driven by those seeking care, or whether it's more supply driven by the lack of supply to serve those who are seeking care.
I'm wondering, Dr. Almeida, if you might answer that. I think that's an interesting question. What drives these wait times in the sense of, is it demand or supply? And I'm also wondering if Member Salinas might want to comment as well.
I definitely think a large factor in this is our we're short-staffed. Yeah. I mean, I think we can get a more accurate look at what the wait list would really look like if all our programs were fully staffed. You can't bring on new clients when you don't have clinicians to work with them. And so I think we've seen, as a program, a steady increase in our wait list times over the last 5 years as our staffing issues have gotten worse and worse and worse. I can say when I started here 9 years ago, people were waiting 2 or 3 months. Now they're waiting 10 months, right? So, and I think that's very, in large part, probably mostly due to staffing. But Angelica has also, you have a picture from other programs, so.
And I completely agree with that. I think it's probably a both and, because I definitely think vacancy rate, and we know that there's a huge workforce shortage, certainly across the state, but across the nation, for people in the health field. So I think we are absolutely seeing the impact of that. But in addition to that, I think we know, since the onset of COVID and throughout, we've seen acuity increase for individuals, both of who's currently being served and I think in the volume of referrals that we've received. So I think that this is a collision of two issues that we're seeing and trying to untangle. And I think as we move towards this current fiscal year and beyond, really capturing that data accurately and having data integrity has been talked about, so we can overlay environmental factors on what we're seeing in terms of the wait time.
Okay, thank you. I mean, it's certainly something to keep an eye on, and I assume you'll be monitoring this as we have future presentations. So thank you.
I think we do need to move on. So if that's okay, Dr. Cummins and Dr. Almeida, so good to see you and the back of the new baby. Congratulations and welcome.
Thank you so much. I am back from leave and officially in my new role as the director of the adult and older adult system of care. And I apologize for having an unexpected work guest today. We unfortunately had a loss in our family, and my husband was traveling to Southern California for a funeral.
We're sorry for your loss, and
thank you so much.
Never apologize for the guest. We got to put him to work early.
Exactly.
So Dr. Cummins, are you going to continue on with the overdose data, or is that Dr. Rose?
No, that's me. And I'm
Dr.
just,
Cummins,
yes.
Hi, this is Jennifer. And just to interrupt, we have a pretty packed agenda. We know you have what, 3 more measures to get through, is that right? Or to present?
I think 3 slides.
Oh, just 3 slides. Okay. Okay. For members of the IWG, this has generated a lot of conversation. And so I just wanted to point that this won't be the only time that you can discuss this. And we might consider doing a discussion group to get even deeper into some of these nuances. So just hold that. If we decide to, we can do something with having a deeper conversation a little bit later on if we don't get to it here. Sorry, go ahead, please continue.
Okay, and you can give me the hook at any time, okay?
Thank you, Ms. James. I do want to mediate your comment, Ms. James, also based upon so many discussion groups and not having the whole IWG there. So that's why these longer conversations are also important. So it's both and. So so thank you for your patience. I know you've got us on an agenda and a timeline, and my focus is to make sure that we have as many members joining and weighing in as we can. Thank you. I know we'll dance. We'll keep dancing. Thank you, Dr. Cummins.
And I'll just also say I'm so thrilled by how interested people are in these data. And we really want to be data driven and use these data to plan and think critically about both what we need and what we need to be doing more and less of. And so we are very excited. I'm thrilled by sort of how deep digging people are. So let me turn to overdose, which and I will do it quickly. And if we need to have more discussion at another point, we're happy to come back and bring our team, who I realized I neglected to invite. We may not have invited today, so more to come. So next slide. So of our metrics that we are seeking to track is our naloxone distribution citywide. Historically, we have been only able to report pieces of what we were distributing as a city. This is specifically naloxone distributed to lay people who may be in the position of either witnessing and or responding to an overdose. Our 2 main sources of naloxone distribution to lay people in the city are the DOPE project. This is a project run out of the Harm Reduction Coalition, and our SFDPH naloxone clearinghouse. So what you're seeing here is a rapid increase in naloxone distribution in the city via these 2 entities, beginning from 2018 to 2019, and then so far peaking in 2021. What you see on the right bar is the first 2 quarters or the first 6 months of 2022. And so that those data do lag. We'll be tracking this at this point at a citywide level, hoping ultimately to get more granular. And this is the first effort to really consolidate naloxone distribution across these 2 major distributors, with more to come. Next slide. And, you know, I'm going to skip this slide for the purposes of time. Next slide. We also track overdose deaths by year and drug class. This is not new, but I want to share with the group as a way that we are tracking overdose deaths citywide. These are overdose deaths that have been adjudicated by the state Vital Statistics Center. So what you can see here is that overdose deaths decreased slightly in 2021, which we did release in a press release earlier this year. The majority of the deaths, as you all know already, involve fentanyl, but many, as you can see in the blue and the light blue, involve a stimulant, methamphetamine or cocaine. More recent deaths are tracked by the Office of the Chief Medical Examiner of San Francisco. These are preliminary overdose deaths, and so don't have the final adjudication by the California Department of Public Health Office of Vital Statistics. And so what we know is for the first 10 months of 2022, there have been 501 overdose deaths that we should consider as preliminary counts. Next slide. As we have shared with this group and which we will be tracking and seeking to reduce profound disparities in who is dying of overdose in San Francisco. And you can see from this slide of 2021 data, again, these are final adjudicated numbers, that Black African Americans, who represent just 6% of the population in San Francisco, comprise 29% of overdose deaths in 2022 to date. Again, this is not final data from last year, but I want to acknowledge how high a priority this is for us in our overdose response. And we have set a goal of reducing overdose deaths and disparities in overdose deaths between Black African Americans and other San Franciscans. Next slide. You can see our overdose inequities and overdose deaths by age and also by gender. Predominantly, overdose deaths occur among people age 40 to 49 and 50 to 59, and by gender, with a male disproportionately impacted and dying of overdose. Next slide. So that is the end of our overdose deaths. I'm kind of leaving it hanging a little bit. I realize, because I'm trying to hustle through. We will be continuing to share with you both naloxone distribution and overdose deaths on an interval that is likely more frequent for our preliminary overdose deaths and annual for our adjudicated overdose deaths. This last slide shows our estimated timeline for sharing additional metrics, and you can see them here. We are hoping by February we will have wait times available for mental health residential treatment, for substance use residential treatment in March, connection to care following an involuntary psychiatric hold or a 5150 in April, and in May, housing assessment and housing placements for people from the MHSF population. So in the next months, we hope to have all of the metrics presented to you except for the quality of life metric, which is presenting the most challenging operational questions for us, which we will be working through. And we should start having repeat customers, repeat metrics as we cycle through the intervals. Next slide. I think that's it. Thank you. Thank you.
Thank you, Dr. Cunnins. Sorry, we just lost a former staff member to fentanyl overdose a couple weeks ago. So the memorial is actually tomorrow. So it's a little fresh for us. And unfortunately, many of our staff members, family members have also passed. So I guess what I'm asking is, what measures are you taking specifically around getting further into the Black African American community around this, because a lot of our regular folks don't understand what's going on with fentanyl, don't know that there's Narcan or naloxone, don't know that there's test strips that can be taken or used to check your substances that you're taking. So I haven't seen what I want to see, which is a campaign and a massive like spreading of like, we need to do this, like urgency. I mean, I see the urgency. I know the urgency on the ground with your staff and team, I'm sure, and with you and with, certainly it's been in the Chronicle and other papers, but I haven't seen it in like on billboards. I haven't seen it, on the T train. I haven't seen it on posters. I'm not seeing it being, out in your emails and in your blasts. We need to, this has to be general, everyday information. And so, because they're unnecessary deaths. So I'll leave it at that. I just wanted to see if there's anything that you can say to that part, and then I'll turn it over if there's any other questions. Thank you.
Thanks, Chair Lasar. I really appreciate the feedback, and I'm sorry for the recent loss. And I know, I am guessing so many of us have recent or even more distant losses to overdose. It really is touching communities so deeply. I appreciate you continuing to push us on this. We, as some of you know, we released an overdose prevention plan earlier this year, in which we outline some of our plans for this coming year, including more public education. And so I share your recommendation. We also have, I also want to make you aware, sort of our email blasts have been going out to the public. They really have been to staff and our contracted partners. We have been trying, just for you to aware, and I know my Ashley Vaughn, who has been managing our communications, is on as well. We do have a regular section on overdose. If you have recommendations, anyone who's listening, for how we might sort of elevate that, make that more visible, we're very grateful for feedback. We've been really aiming to include this regularly so that we are, in order to raise an awareness. I realize this is not the same as billboards and radio and messaging, but I hear that loud and clear.
Thank you. Are there any other hands from the IWG, or anyone want to comment before we move on? Okay, not seeing any hands. Thank you so much to you and your team, Dr. Cummings.
Huge thanks to the team for all of this work. I'm just want to let you know I'm going to transition to phone, but I will be here, but off camera. But just need to transition my body to a different place, so I will be listening in. Thanks.
Thank you so much. We are moving on. Ms. Sadka, please take us to public comment.
Sure thing. So those that would like to provide public comment on this item, you'd call 415-655-0001. Access code for today is 2488-316-2188. And an additional step for today's meeting is a webinar password as well, 1234, and then you'd press pound and then we'll dial *3 to allow it to speak. I'm seeing if we have any callers. Currently, no callers, but I will wait a little bit longer. Since there are no callers in the queue, I'm going to close public comment. Back to you, Chair Lassar.
So let's go ahead and take a break. It's 10:27, so let's give us a couple of extra minutes. So how is 10:33? So we'll see you soon, or 10:35 really. So we'll see you at 10:35, and thank you. Please remember to go off on your camera and come back when you're back. Jen, how are we doing on time?
Pardon me?
How are we doing on our time?
We are at 10:35 and we're really good. We're only 5 minutes behind.
Great, great, great. Okay, thank you. How's the weather in San Diego?
It is sunny now, but it was raining the last several days.
Yeah, we were too. But it's cold here. I don't know what it's like down there.
Definitely, well, whatever cold means to us in Southern California, but it feels cold for me.
Yeah, it's been about in the fit like 50 something but in the evenings here, so it's cold for us.
I think do we have everyone back? Do we have quorum back?
Looks like we are possibly. Think we're missing a couple, maybe. If you're back, please do turn on your camera if you're able. So I think we have most everyone. So it looks like should we get ready to go?
Yeah, I think so. A note to the IWG, the PowerPoint that you have, there's 2 items that are going to be flipped later on. So we're going to listen to this next item coming up, and then we're going to hear the implementation report, and then we're going to go back to Mental Health Service Center. So the public agenda is correct, but the deck that I sent you is not. So I will be resending that in just a little bit. And Ash, I'll be sending it to you so you can open it up after this agenda item.
Okay, so we have discussion item number 5 then?
So
And
the,
staffing?
yeah, so the
where we are?
public agenda is correct. It's going to go, first it's going to go staff and wage analysis, then it's going to go implementation report, and then it's going to go mental health service center. It's just the PowerPoint itself doesn't match that.
Okay, so discussion item number 5 is where we are now. So we will be having the controller's office updating us. We welcome Wendy Lee, Glennis Stars, and Kat Benson. We also welcome the feedback of those members who attended the November 17th wage and staffing discussion group, which was members Salinas, Eisen, Fields, and myself. Next slide. And I will turn it over to you all. Thank you and welcome.
Thank you, Chair Lassar. This is Wendy here speaking. I'm sorry that I can't be on camera. My computer decides it didn't want to recognize my camera, so apologies that I can't join you there on screen. But thank you for the introduction. And thank you all today for the time this morning to share with you all IWG members what our updates have been on the Mental Health San Francisco staffing analysis and to hear your input and questions. We really appreciate your all's experience and the expertise that you're bringing to this conversation. And as Chair Lassar mentioned, we're really grateful to have gotten to already tap into the expertise last month with the IWG discussion group. So we'll get to talk a little bit more about that and lift up the feedback that we heard from the group. Just to level set with where we're at, it's been about 3 months since our project team last came to you all and shared an update in the IWG monthly meeting setting. I think we have some new faces on the team. So Chair Lassar, thank you for introducing our team. Glennis has been with the team, which we're excited about. Kat Benson is new, and so we're excited to have her join. And I think last time you heard the update from this project, it was from Heather Littleton. Right now she is off on an amazing adventure, so I'm getting to step in and be a project manager on this analysis. So wanted to orient y'all to some new faces on our team. And to ground our discussion today, last time our project team came to y'all, we shared our project approach, what we were planning for our areas of analysis, and what our estimated timeline was. And so again, 3 months ago, we were in the earlier stages of our project. We had completed project scoping, but had not yet dove into the actual project activities. So for today, what we would like to cover with you all and share and get your feedback on is we're going to just reground the discussion in our project approach to refresh everyone's memories, to share what we've been working on since we last came to y'all, and what we'll be working on next and our timeline. So with that, next slide, please. Okay, I think you all are very familiar with this and the legislation, but I think it's always helpful to continue to ground the discussion based on the mental health SF legislation. So as a reminder to the group and a reminder to ourselves, the legislation asks for a staffing analysis to tackle 2 things. First is to determine whether there are staffing shortages that are impacting the delivery of effective and timely behavioral health services. And this requires looking at both CBO and civil service providers. And then secondly, to provide recommendations on appropriate salary ranges and working conditions in order to attract and retain staff where we identify those most significant staffing challenges. The Controller's Office is currently taking the lead on this analysis, and we're continuing to work with DHR and DPH on data collection and bringing regular updates to you all at the IWG to get feedback. Next slide, please. Thank you. So what are we currently working on? You'll see the title of the slide is phase 1. So this project is really what we're prioritizing is trying to identify those critical positions and services that we cannot staff and retain well that are impacting service delivery as mental health SF is being implemented. We know that there's been a lot of important anecdotal discussion of hard SF positions, both in the city as well as on the CBO partner side. And so this is a focused, targeted staffing gap analysis in our current status quo system. So we're going to use existing data and analysis and review whatever performance data may exist in order to identify where service bottlenecks are and to identify where those most significant staffing gaps are. Once we've identified those, we will do a deeper root cause analysis to identify what's causing those gaps. And the goal of this kind of phase 1, what we're calling, is to be able to recommend some short and medium-term strategies where the city can start addressing these problems while mental health SF is continuing to be implemented. And really want to underscore this because we see that mental health SF, really is a long-range initiative. And so this kind of phase 1 staffing analysis is intended to try to give us some actionable, or give the city hopefully some actionable strategies in the near term while mental health SF is still being implemented. Next slide, please. And so what we've listed here on the slide is a potential phase 2 focus. This is not currently what we're working on, and I just want to distinguish this. Phase 1 is not this full staffing model based on the projected demand in the ideal state for mental health San Francisco. In order to do a future, full staffing model, we would need to be able to have more data on wait times and demand as once mental health SF services, oh, what a tongue twister, are implemented. And because mental health SF implementation is still underway, we can expect demand to continue shifting. And so conducting a full staffing model as a phase 2 after there's been further implementation of mental health SF, for example, with the Mental Health Service Center, Office of Coordinated Care, would provide more data on demand and service utilization as those services are being stood up. And those data systems and processes are also established to support the capture of that information. So this future phase 2 would build on the work that we're currently doing in this phase 1. Next slide, please. Okay, I'm going to pass it over to my colleague, Kat.
Thanks, Wendy. So this slide is detailing our approach for the phase 1 analysis. As Wendy shared, the project objective is a targeted staffing gap analysis based on current measurements of service demand in the status quo system. So the first step of the analysis is to identify mental health SF staffing gaps. The project activities for this phase are qualitative interviews and analyses of available data. And in this step, we hope to answer the questions where there are the most significant staffing gaps in mental health SF services, and based on available service and performance data, where there are gaps in mental health SF service delivery. So the second step is analyzing staffing gap root causes. The project activities for this step are focused interviews with CBOs and city staff, analyses of available data, a potential survey for CBOs, and benchmarking. And in this step, we hope to answer the questions, what are the barriers to full staffing? Are there issues with hiring processes, retention challenges, working conditions, or something else? And finally, the last step is to develop wage and conditions recommendations. So the project activities for this step include benchmarking, insights from qualitative interviews, and finally, to develop the summary memo. So we hope to answer the questions, what are the potential staffing strategies for San Francisco? And what are strategies that other jurisdictions or health systems have implemented that have been successful? So you might wonder where we are in those 3 steps. We've mostly completed step 1, identifying mental health SF staffing gaps, and we have started step 2, which is analyzing the staffing gap root causes. Next slide, please. So this is some more information on our key project activities to date. We have conducted informational interviews with BHS, Supervisor Ronan, the Department of Human Resources, and other Department of Public Health staff to understand the project needs. We've consulted with the DPH and Supervisor Ronan to scope the project and to prioritize the current state staffing gaps and short-term recommendations that Wendy described earlier. We have interviewed systems of care directors within DPH, BHS to better understand the positions and programs with the worst staffing gaps. And we also held the IWG discussion group where we shared qualitative themes and consulted IWG to better understand the CBO staffing gaps and how to develop our CBO outreach strategy. Next slide, please. So in these interviews that we've completed so far, we asked more or less the following questions. So from your perspective, where do you see the worst staffing gaps? In what programs and in what positions? And what do you think are the root causes of these staffing issues? And finally, how do you measure performance or success as it relates to your program performance and staffing? Next slide, please. So this slide details the outcomes of our interviews to date. So in our systems of care meetings, we found that across the board, interviewees mentioned special difficulties hiring for licensed providers at the city and CBOs. However, we also heard from some CBOs that many of their counselor and case manager positions don't require licenses. So we therefore landed on an updated approach. So we will be doing a deeper dive to understand the root causes for staffing challenges in both licensed provider and non-licensed case manager counselor positions in both city-provided and CBO-provided behavioral health services. So that means that instead of looking at all positions, we'll be looking at two key positions: licensed providers, which at the city have the title of behavioral health clinicians, and non-licensed case managers, counselors, and they at the city have the title of health workers. We also wanted to lift up some of the feedback from the IWG discussion group. So participants shared that there's an ecosystem of staff needed to maintain various levels of service. They also shared that staffing issues in other positions, for example, nurses and physicians, also have an impact on service delivery. And finally, they shared it was important to broaden our focus to include other case managers and counselor positions to allow us to look at the biggest gap in the near term. So we will be doing this and broadening our approach to look at both licensed and non-licensed case managers and counselors. Next slide, please.
Kat, just one thing on that as well that I want
Yeah.
to chime in on is that we also noted that we really need to build a pipeline. And then without the pipeline, which is, high school, undergrad, grad, et cetera, we're not going to, and licensure, we're not going to be able to get what we need. So we have a significant challenge. I mean, we've known this for the last 15 years. I think under Director Barbara Garcia, we knew that with the baby boomers retirement, we were going to be even in worse challenge. So I can't iterate enough, and I would love to see that that point it be included in your somewhere in your presentation as well. Thank you.
Yeah, absolutely. The pipeline is really important. I believe that we shared it later on in the presentation, but if not, it should definitely be included. Should I continue on?
Yeah, it's your call. I think Member Wong also, who was present, wanted to chime in. Member Wong?
Oh, sorry. I can't see hands.
Oh, no, that's okay. That's why I'm here.
Okay.
Hi, thanks, Chair. I wasn't present at this particular discussion, but I do have, a question. Just kind of looking at, I appreciate the information about, for future kind of consideration, looking at the licensed and non-licensed people, to fulfill, to assist the population that we are looking into. So I'm just kind of curious, when we are looking at licensed and non-licensed, then of course, then we're looking at pay differences. Then also, then the experiences, I mean, the people, when we're looking at the non-licensed and licensed, are they good, what kind of task or what kind of responsibilities they will be, doing working with this type of population? I mean, I would imagine a licensed person, one, probably get paid more. Two, the workload will be a little bit different than the people who are non-licensed, right? So I'll be interested in those differentiation and the data as well. Does that make sense? I just want to make sure I understand the question and that I am asking the question to get clarification on what I'm asking.
Yeah, thank you, Member Wong. I want to make sure I'm understanding your questions, if you'll bear with me here. I think what I heard was you're curious about the comparison between licensed providers and non-licensed providers. Is that correct?
Yes, yes.
Yeah.
Because you mentioned that you guys going to be looking into that, right? So of course, the licensed and non-licensed going to definitely have different responsibilities and accountability as well. So yeah,
Yeah.
and then working with this population is pretty challenging. So
Well,
that's
absolutely.
yeah.
Thank you, Member Wong,
Thank
for
you.
helping clarify. Yes, no, I think you bring up several really important considerations. And I want to clarify that for our analysis, we're looking at both licensed and non-licensed. And, I think you bring up an interesting point. I think we haven't yet reached the stage of our analysis of kind of exactly kind of where the comparisons will be. I think right now in our current work, what we're planning to do is, just be able to do a deep dive into both those positions. And so I think, Member Wong, we really appreciate your insight into some of the things that we should keep in mind. I think at this stage, right now, we just want to understand kind of what are driving significant staffing gaps in both those positions. I think what seemed to come up qualitatively in some really early preliminary data is that kind of both those sets of positions are kind of among the most significant. And to your point, Member Wong, they do provide different kind of levels of service and different range and bring different skills and expertise. So I think we appreciate your insight that we need to hold those in consideration. And to that point, I don't know that we're at this stage not necessarily proposing or imagining comparing those kind of like licensed versus non-licensed, but I think comparing all those, looking at the full scale of what's impacting staffing gaps at both of those levels, not necessarily between each other, but across both of those. So hopefully that helps. But really, Member Wong, thank you for that question.
Are there any other questions right now?
I guess Vice Chair Patterson has their hand raised.
Yeah, I would just really recommend that you look at hiring locally, if possible, as well, to deal with the population. And there's people who may have experience who might not be licensed, and then also, because especially like in this field, or I would say maybe we should look at um, possibly providing information on how people can be licensed as well, because this is a career choice that people can take. That's all.
Thank you, Vice Chair Patterson.
Yes. Thank you, Vice Chair Patterson. I really appreciate that in hearing that it's important to think about where thinking about the pipeline, also echoing what Chair Lassard, what you've mentioned as well, and also that it's important to factor in licensed and non-licensed providers, recognizing it is this ecosystem. So really appreciate hearing that and your insights, Vice Chair Patterson. And also, we'll definitely be sure to note that in looking at where are new hires coming from, and are they local, are they outside the city, wherever possible, wherever data does exist to look at that. So thank you for that. All right, I'm going to pass it back to Kat to lead us onward.
Okay, I'll move forward, but feel free to let me know if there are any other questions. Thank you. So as a next step, we'll be doing a root cause analysis for the city positions that we identified, the behavioral health clinician and the health worker. We'll be reaching out to the Department of Human Resources and DPH HR to gather data on the root causes of staffing gaps in these positions. We'll try to answer the questions: how long does it take to fill these positions? Do sufficient qualified applicants apply? Where in the hiring process do we lose qualified staff and why? Where do our new hires come from? And how long are people staying in these positions and why do they leave? So these are some of the questions that we hope to answer with this analysis. Next slide, please. So we will also be doing a root cause analysis for CBO positions. So we will be taking a slightly different approach for this analysis. The first step will be reviewing existing CBO data sources. So reviewing notes from CBO interviews that the Con Nonprofit Wage Pressures team completed last year, and also reviewing incoming data from the Con Nonprofit Wage Equity Survey. And if you could click through the next couple of visuals, that would be helpful. Thank you. Great. The next step is to identify data gaps. So looking at where we need additional information from nonprofits and thinking critically about the best way to collect this information. And then finally, we'll be doing outreach to our CBO partners. So we'll begin targeted outreach to key CBOs from which we need to gather critical information. And one important note on this is that we want to emphasize, the emphasis, is on to limit the lift required by CBOs. CBOs do extremely important work and therefore have limited capacity. And so we want to limit the additional burdens that we place on CBOs to complete this project. So that's something we definitely want to be thoughtful about. Next slide, please. So we'll be reaching out to a range of CBO providers to make sure we have a diversity of organizations represented. We'll look at some potential root causes for CBO staffing gaps, including wages, benefit packages, pipeline issues, and limited pathways to licensure and staff satisfaction. So we also want to highlight here some more feedback from the IWG discussion group. We heard that wages have a direct impact on waitlists for services and whether people are receiving the right level of care. Also, for any future policy implementation, it's important to think about the implications of the difference between city-funded and non-city-funded programs within an agency. We should center equity in the analysis to make sure we're including agencies serving populations across the city. And when thinking about recommendations, it's important to consider how we integrate potential advantages of working in nonprofit settings, such as community atmosphere and flexibility. Next slide, please. So I'll pass it back to Wendy.
Thank you, Kat. So on the slide here, we wanted to share kind of our latest estimated project timeline. So right now we're in December. And what we anticipate, we've started doing some outreach to start gathering data on the city side to understand kind of what are the root causes for staffing gaps on the civil service space. And then we're simultaneously, as Kat described, doing a review of our existing CBO data sources to understand what are some of our remaining or outstanding data gaps to really be critically thoughtful about how we're doing our outreach to CBOs to minimize that administrative burden. So all to say right now, and heading into probably the next 2 or 3 months, we are going to be in kind of the data collection phase of our project. And as you heard Kat describe, we envision that that's going to be a mix of qualitative interviews and outreach to folks in the CBO space, as well as on the city side, and reviewing the existing data that exist, again, on the city side and on with CBOs. And so I think one thing to highlight here is that we are targeting late spring, kind of the March through May phase, where we're going to be developing recommendations and being able to come up with a summary of our findings and potential strategies that the city might want to consider. So that's our general timeline. And next slide, please. Oh, and then actually, if we go back one, if that's okay, I think there was one additional thing in talking through it, just to recap our next slides is, so as Kat mentioned, we're requesting data from DPH Human Resources and the Department of Human Resources for civil service data collection analysis. We're going to be identifying data gaps and planning outreach to that sampling of CBO providers for the CBO data collection analysis. And we're also going to be conducting benchmarking and best practices research, as Kat mentioned, to try to understand kind of what are some other strategies that other jurisdictions or health systems may have implemented that San Francisco ought to consider. And so that wraps what we've prepared for slides today. And I think want to open up to the group to ask, for those members that were able to, that joined us in our November 17th IWG discussion group, are there any additional highlights that you'd want to lift up for the group that we might have missed? And then also, what questions or suggestions do you have for our project team? So I'll stop there and thank you all so much for this time.
Thank you. I'm looking for any hands or anyone who, Member Fields, please.
I just want to compliment the team on this work. Having participated in these discussions with a lot of nuance and coming at it from a new perspective for folks, I thought this really captured the points that were made and captured them well. So really top-notch work from the whole team on this. I'm looking forward to seeing the follow-up with this, because you're pretty thorough and you listen and you pick up, as far as I'm concerned, you picked up the important parts from this perspective. So thanks for your work.
Thank you, Member Fields. Member Salinas?
I would echo what Steve said. I think that we're probably for the CBOs that we're looking forward to these meetings in January to February. We have really been trying to track with our staff who are separating, with as many as will cooperate, why they're leaving and where they're going. So we have that data. We've also been tracking new vacancies and the length of time to fill vacancies. So I think that I'm hoping other CBOs are doing some of this, so that, I think that's information that would be really helpful to the wage and data analysis. And I guess I just want to point out for us as the IWG, that, it's very much needed and appreciated that a controller is doing, system-wide, not just, for mental health providers, but, all the CBO contractors, this staffing and wage analysis. And that I think, when these reports come out, for us as the IWG members, just really thinking about how we're, because this still needs to be budgeted, right? That's a whole other thing that's not up to the controller. You'll do all this work, months and months and months of work. What is that going to translate to? And so how in the IWG we might put into our work plan for the next year, once we have this data that we've been requesting, how we're going to move it forward. Thank you.
Great point, Member Salinas. Vice Chair Patterson, is that a new hand or?
Yes, that's a new hand. So I kind of have my thoughts together. So I just want to reiterate providing, information about how to get licensed, because in this field, where you work with people who have mental health issues, whether you're a mental health provider, whether you work in the shelters, what happens is, like you do have people that are getting the certificates and things like that, but you have people that are experienced that don't get the certificates, and then you have a lot of unexperienced people as well who aren't trained at all. And so I think, with this being 2022 and not the 60s, I think mental health is a real career choice. And I think, working with people that have issues takes some skill. And it's a valuable career choice for people who may work in the shelter system who aren't really trained, but they're kind of learning on the job. people who may work in the mental health system, but they're not really trained, but they're learning on the job. There's a lot of people, even somebody that does security. There's some places that deal with people with mental health that have security there that actually have an interest in working with people. So I think it's very important to provide the ladder in the outreach and provide the ladder of pursuing this field. There's people probably in high school right now who don't realize that this is a real career choice. And the reason why I say it's the 2022 and not the 60s is because, I mean, mental health issues is a serious thing. And especially in the Black community where I come from, we need people that can relate to people. So this is even a viable career choice for a lot of Black and brown people. So with that, I'll land the plane.
Thank you, Vice Chair Patterson. Wanted to reiterate what you just said. Many of the most skillful people I've seen are some security folks who are dealing with de-escalation in spaces. And I see Member Salinas smiling. There's a real need for folks who have compassion and who just need the opportunity and the knowledge that these are areas open to them. So I'm really looking forward and really throwing down the gauntlet to Director Cummins to see what we can do on this pipeline. So I'm excited about that. Thank you, Vice Chair Patterson. Really important points.
Can I add something? Just thinking about what Co-Director Patterson was saying, and something that it just occurred to me with this staffing. The wage analysis is also just maybe looking at. I'm sure there are huge discrepancies, right, in what the pay is for the peer counselors and the non-licensed counselors that are I think that are increasingly being relied upon with the staffing shortages for the folks with more training. And so I maybe just looking at that because I wonder, they're probably not making a living wage for San Francisco. And so looking at how we can better compensate folks with BAs and with lived experience who are trying to stay out of previous systems. I'm having this huge issue right now trying to hire a peer that I can't get cleared because she has a record, but this is still for her a good opportunity versus what she's doing before. So just looking at those barriers for hiring and retaining peers and BSW level counselors. Thank you.
Thank you. And the barriers are the piece that we need to make sure we have added to the analysis. Now that you also bring that part up. Thank you. Member Vice Chair Patterson, is that a new hand? I don't want to.
That's an old hand. Let me lower
Okay,
it.
thank you. Okay, so back to you, Kat, I believe.
Yeah, I'll jump in real quick just to say thank you all so much for this really, really valuable discussion. Thank you. I think there's a lot of just really good insights shared, and we'll marinate on this. We have notes. We'll look forward to the notes from the IWG as well, and we'll definitely be sure to integrate these as we are starting our qualitative data collection on both the city side as well as on the CDO side. Just want to express our gratitude for your all's engagement and weighing in and sharing your expertise. So thank you so much.
Thank you so much, Ms. Benson and Ms. Lee. Excellent work, and also echoing my co-members in your ability to synthesize and keep it moving. Just don't forget to add pipeline for me, please. And I guess, Ms. Dodka, are we going back to you now for public comment?
We are. So those of you who'd like to provide public comment can call 415-655-0001 and access code for today 2488-316-2188. And then you'll use this webinar password 1234. Then you press pound and then you'll dial *3 to line up to speak. We're going to see if we have any callers. We do have one caller, so I'm going to unmute you and you may begin your comment. I'm noticing that as not the host, but the co-host for this meeting, that I had to request an unmute, and it looks like the host allowed me. So caller, you've been unmuted. You may begin.
Hello?
Yep, we can
Can you
hear
hear me? Oh, okay. I'm sorry, I missed part of the beginning of this. I was wondering if the analysis was done that included all the positions, all the open positions in DPH, or was it just the new positions that are being created through this process? Thank you.
Thank you. Chair Lassar, our understanding is that we can't respond to questions, but let me know if you have any immediate reflections on how we just don't address. Or
I think that we could allow generally a comment by someone from DPH or from the office, a general comment, if there is one. I'm looking for hands. I'm not seeing any, but I don't see all of the other folks. Yeah, I'm not sure. So I think we can work on getting some kind of general response. That's not specific to the question, I think is what we can do. So thank you, caller.
Thank you.
Also, I believe that if you send an email in, we can respond via email, I believe. So is that IWG at something? I forget the email for that.
Yeah, Oksana, are you able to share what the email is that callers can email
I'm
questions
just pulling it up.
to?
One moment.
Chair Lassar, I wonder, as a member of the working group on this and the content of the discussion, my assumption is that that the work includes the current conditions of the mental health behavior or the San Francisco behavioral health system, not just the new programs. It's not limited to that. She mentions that an adjustment will be made on new positions that are affiliated with the particular projects we're looking at. But the legislation itself calls for an expansion of the system of care more generally. And in the work with the controller's office to date, they've been looking at positions and situations that support the existing system of care. The mandate of the legislation is it doesn't replace anything we have. It builds on what we have. So we're looking at the whole system of care, both city side and CBOs.
Thank you so much, Member Fields.
Thanks, Member Fields. And Oksana, do you have the email just for future, even though we did get a response?
Sure. Yes, the email is mentalhealthsfiwg@sf.gov.
Thank you.
Thank you. Shall we move on to discussion item number 6?
Yes, and to my understanding, we are jumping to discussion item 7, and we'll come back to 6.
Correct.
Oh, okay. I don't have the slide for this. What page is it?
It is 61 that we are jumping to the December implementation report.
Oh, that's not the number in my deck. If you all can go ahead. Oh, wait, no. Ms. James, if you can get us started so I can catch up.
Yeah, happy to. Thank you. And thank you for everyone for the patience with some of the challenges we've had with this meeting. Yes, so the December implementation report, just wanted to reiterate the purpose of this report is we concluded it here. There's a legislated requirement that that this group would submit to the Board of Supervisors, Mayor, and Director of Health its final recommendations concerning the design of Mental Health San Francisco and any steps that may be required to ensure its successful implementation. So that's a legislative requirement. And the purpose of the report that we have is to consolidate and share all the recommendations completed so far, because there are some that are still being, there's some components that are still being designed. And so it's not that the recommendations have been totally completed. So what we wanted to do was consolidate what we have to date with all the recommendations that the IWG provided, is identify future recommendation and processes, and really be able to edit that recommendation roadmap, maybe identify some additional things that we should be doing, and offer suggestions to enhance the success of Mental Health San Francisco. So the legislative requirement is something that is that we are doing, but we are doing it in the spirit of how this work has evolved with all of you. Next slide. So the way that we did this is we wanted to facilitate a co-developed report that was between DPH and IWG. So there are two parts to this report. Part one was really a focus on review of the progress of the IWG. And part two was a review of the focus of the future of the IWG. So part one, which was review of IWG progress, that section outlines the IWG's progress on the 4 components. And to develop this, our team pulled the recommendations suggested by the IWG and then reviewed past minutes to pull out progress as reported by DPH to the IWG. After we did that summary of everything that happened over the last couple of years, DPH then reviewed and confirmed our summary, and we sent that to IWG members to independently review and provide feedback directly to us in keeping with Brown Act rules. So that feedback that we received from all of you, we then integrated into the draft, and we have a couple questions that members raised that we will review today together. Now, part two, which was the future of the IWG, engaged the IWG and DPH in the opposite order. So first, an IWG discussion group met to develop some concepts for the future of the IWG. They then brought those ideas to the larger group for a public discussion at November's IWG meeting. And then feedback was integrated and sent to DPH then, who they then reviewed it and provided feedback to us. It's of note that there were no modifications that were suggested to the IWG suggestions. There were suggestions about how to implement it and some details about what it might look like that are not about the content of this report, but more like clues for how we might have a discussion about implementing it together between DPH and IWG. So a final draft was circulated to the IWG prior to this meeting, and then that was also posted to the IWG website for the public. And our conversation today is to provide a final opportunity for feedback and a chance to address a couple of key questions that I mentioned earlier. Before we go to that conversation, I just wanted to check in and see if there were any questions about the process, or if anyone has anything about how this evolved over time or amendments. See any hands up?
Not seeing any hands.
Okay. Thank you. Okay, so if we could go to the next, stay here. Can you go back a minute, Ash? Just to point out, like I highlighted on this slide where we are. So that's where we are, is that we're sharing alignment. Those final comments from today will be integrated, and then DPH has a final review, and then it's going to be submitted on December 27th. So that's when it will be finalized, final. Thank you. Wondering, Ash, if you can pull up the IWG report and share that. Are you able to do that? I put the link to the public, to the website in our chat.
I think if you already have it available, Jen, this I can stop sharing my screen if you want to go for it.
I don't know with this new website if I can share my screen.
Yeah, I would just give you capabilities. Okay. So I'm going to stop on my end.
Thank you. Are we, where are we now? Are we back to discussion item number 6?
So we are talking about we are now talking about the mental health implementation working group implementation report.
But
So-
I'm not seeing any comments. So sorry, I lost track of what.
Oh, that's fine.
Okay. I was
Yeah.
like, okay,
So-
now got you.
So there was we received comments from 2 different members. One of them was verification about how we did some of the process. The other one was more content related. And so what I thought we would do is I'll just for those of you, I hope you've all had a chance to look at the report, but I'm going to overview it here just to make sure that all IWG members kind of have a feel for the flow of it. And if there are any questions, we can stop along the way. And when we get to the appropriate section, I'll pause for the comment and question the member raised. So, and this is available on the IWG website for anyone who wants to go there under this meeting. So after the overview, which is pretty a standard overview, we talked a little bit about the IWG's work in its context. Because it did take place in a pandemic. That's kind of been the context and what we've operated in over time, both by virtue of having virtual meetings, as well as just how the work has actually flowed, because DPH needed to get started on some pressing things before the IWG actually convened. And so that's kind of what you have often talked about at the IWG over time, is that it's sometimes felt like you're playing catch up while DPH was trying to be responsive. And so this is kind of a time to true up all of those different approaches. We did go back and review the overall progress. There are 5 different roles that the IWG is tasked with by legislation: the role of an advisor, the role of an evaluator, the role of reviewer, of analyst, and a strategic budget and scoping advisor. So briefly, like the role of the advisor is that they would advise on the, as Chair Lassar reads often, is the design, outcomes, and effectiveness of mental health San Francisco. And the progress of this is since December 2020, the IWG has met monthly, and they've advised on all 4 of the 5 domains of mental health San Francisco. That 5th domain has to do with the Office of Insurance, Public Insurance and Accountability, I think it's called. In any case, it has not been designed or is part of the scope of this work now, because we have those 4 other domains of Street Crisis Response Team, Office of Coordinated Care, Mental Health Service Center, and New Beds and Facilities that we've been focused on. And you have done all of the reviews. We've done recommendations for all of them to some extent. As I mentioned earlier, some of them are not yet designed sufficiently by DPH to be able to do a full recommendation that has to do with Mental Health Service Center and with OCC in particular. The role of the evaluator is that the role of the evaluator is the IWG should evaluate the effectiveness in meeting behavioral health and housing needs. And the IWG has provided feedback on the design of these overarching approach, and all of these metrics that you're just reviewing right now will be future opportunities to get further into that and to serve that role in a more robust way. You also have the role of a reviewer. And so the IWG is tasked with reviewing and assessing the implementation plan of the Department of Public Health. And so that will be coming up in 2023. DPH is going to be coming to the IWG to present on what their implementation plan, and that will begin that recommendation or reviewer role. You're also the role as an analyst. And so you're legislated to conduct a staffing analysis of both city and nonprofit mental health service providers. That's just what we heard about today a little bit. And the Comptroller's Office is doing that on behalf of the IWG. And so that is also, you've had an opportunity to do some feedback, but there's going to be a lot more work, and it'll be completed in 2023. So deliberation of that will be picked up in the new year. A final role is strategic budget and scoping advisor. And in the legislation, that's specifically related to if mental health service center, if the cost of those services exceed $150 million annually, it is your role to advise on that and to prepare proposals about how to reduce the scope of those services. That hasn't happened yet. That hasn't exceeded 150 million annually. So those are the 5 roles. What follows next is we go to each of the domains: Street Crisis Response Team, Office of Coordinated Care, Mental Health Service Center, and New Beds and Facilities, to talk a little bit about what the initial recommendations are and what DPH's response has been. Before I move on, I want to know if there's any questions that anyone has about these 5 roles or any clarification that I could provide. Chair Lassard.
Sorry, I was just looking for hands. Did anyone have any comments or questions?
I have a comment under role of the advisor, and the list of all those different bodies that the IWG is intended to advise on. There's the overview of progress. It only mentions the area of mental health SF that we have not advised on, but doesn't mention the different bodies.
Those domains.
Yeah, is that? Is that?
Yeah, we could list those out if that's helpful. We can put that in there just to make it.
No,
clear
not the
which
mental health SF domains, but the
Oh.
different bodies that we have not directly advised on. Is that not important, or?
Sano or DPH, is there a response to that?
Sorry, can you repeat the question?
Yeah, in the first under role of the advisor, it lists the different bodies that the IWG is tasked with advising. And of those, from my read, I think the DPH is the only one that the IWG is directly advising. And yet in the overall overview of progress, there is, it only mentions the one of the 5 domains that IWG has not advised on. It doesn't mention those other bodies. Yeah. So I'm just wondering, is that important, or is it something that we should comment on in the progress?
I would concur that we should comment on it in the progress.
Well, and I want to make sure that I'm understanding as I hear you say that, Member Hammer, it's the office of, in the overview of progress, the 4 of the 5 domains for Mental Health Service Center are those 4 that we've been advising on. The 5th domain is that Office of Private Health Insurance Accountability. That's actually a 5th domain in mental health San Francisco that we haven't got to deciding or to be able to deliberate on. That is different than when you mentioned above the role of the advisor is the Health Commission, Department of Public Health, Mayor, Board of Supervisors, because this report is submitted to those bodies because they are advising them. You are advising all of them through DPH on what should happen. So I think I hear you putting the Office of Private Health Insurance.
So the report is our advising of those all those bodies.
Yes, it is a summary of your advising that you've done over the last 2 years.
Okay.
Does that make, is that satisfactory?
Well, not really. I mean, it's a report on our advising over the last 2 years, but if we haven't advised any of those bodies except for the DPH, then should have mentioned that. Do you see what I'm saying? Or does the report itself count as the advice to the Mental Health Board, to the Board of Supervisors, to the Mayor?
I think I understand what you're saying. It sounds like there needs to be perhaps a clarification of language in terms of kind of who is tasked with the implementation of this work and then who is receiving advice. It sounds like perhaps kind of a languaging concern that we can circle back to, but that's noted.
Yeah, and just clarifying what advisory role this body IWG has taken on.
Right. Okay.
Okay.
Thank you, Member Hammer. I saw Vice Chair Patterson and Member Fields. Vice Chair Patterson?
Yes. And I think what Member Hammer is asking is if we're advising DPH, and how much of our advice is DPH taking and advising the other 5 bodies?
Yeah.
Also, in layman's terms,
Yeah.
but also, I guess it's a concern, and maybe a point of direction. And I know I've missed meetings and stuff, but we're mental health SF, and I'm not sure if we've brought on any of the mental health clinics. So I find that interesting. And you know, and how many mental health clinics do we have? I think we have 3 or 4 in the city. So I'm just looking at this from the standpoint of if I was a patient,
Mm.
or no, if I'm looking to be a patient, right? I'm looking for mental health services, you know, access, and then first thing I think about as far as being in the field is waiting lines or waiting lists, right? But I'm still thinking about access for, like, you know, especially for people in Bayview and different parts of the city. You know, one thing about it, there's still a stigma to mental health, which there shouldn't be. So that provides a barrier for somebody that doesn't live in a TL, right? You know, per se, because the TL kind of, you know, is kind of used to that culture. You know, and there's mental health clinics that's kind of around there. So, and then another thing too, see, because like listen, you know, being on the panels, a lot of these fields bleed off into each other, where it's the homeless field or the mental health field or the drug abuse field.
Mm-hmm.
So, because of COVID, the system we had in place is gone. That's why I think about access. You know, the system we had in place is gone. And so, with the average person, because I'm with the people every day, what the average person struggles with is being able to find stuff. And, you know, the problems the average person goes through is when they go to these places, they run into people that don't know nothing. That's why it was important, you know, talking about staffing earlier. But they run into people that don't know nothing. It's a crapshoot between running into somebody that's been in the field long enough, that's experienced, that can point you in a direction, to like going somewhere and being told to go there, then go there, then go there. It's not a layout. You know, before COVID, there was like more direction on where services were. And this is what you do, this is the process. After COVID, it got thrown out of whack. And I'm not sure if, and it's not just on you, but just with a lot of the social services, I'm not sure if we made that adjustment of really providing direction. You know, we're kind of like number crunching.
Yeah.
And so I land the plane there.
Thank you, Vice Chair Patterson. I think that's a big part of the work, the mapping work, and I think really the other part of mental health SF that I've been alluding to, and I directly saying to Dr. Cunnins, which is the communications piece. We've got to get our communications piece, the media piece. There has to be some shifts in these pathways that you're speaking to on all levels. So I'm 1,000% in agreement. In terms of the clinics, I think is there something specific around this this report that you want included, just to make sure that we're clear?
Well, like at least, okay, how many clinics are in the city? I think there's 4. Where they're at, what's the process to getting a psychiatrist, and then what services they provide. I think we should know that in their location. That was clear before COVID. It's not as clear now.
Yeah.
For today.
Thank you. Thank you.
And Vice Chair Patterson, I just wanted to I did go up in the report. We have this concept of the legislation and how it's been developed. We probably need to come back and refresh this. We've been talking about that. This is a little outdated at this point, but the original concept, like even under the Office of Coordinated Care, there's just marketing and community outreach. So, I think, and then there's like centralized access under mental health service. I just wanted to point out that there are elements of what you're saying, I think, in the legislation and that are being designed, but they're not there yet. And so I that's also what I hear you saying. And I wanted to confirm, is that kind of what you're interested in kind of going deeper into?
So if like people might not know this about me, but my mom fed the homeless for 30 years. She ran United Council, Mother Brown's drop-in center. Barbara Brown was my mother. So, what she had on the walls and at the office, any peer monitor could become a seasoned counselor just by looking at all of the stuff she had listed on the walls. There was one section where you could find everything that was in the city. And I actually remember her like building that database, going, and back then you didn't have the internet. So she was literally going places and meeting with I thought it was crazy, but then what I saw was she, created and put it on the wall.
Yeah.
So like we had a clear direction of what to call, and that's not even the solution because sometimes people don't pick up. But at least you got 5 or 6, 7 people to call. So I'm saying something like that.
And to your point, something that's very accessible. Like you can look at it and say, "This is what I do."
Right.
Yeah.
So like if you're dealing with somebody that's a woman that's coming from a battered situation, about 3 or 4 places to call. At least. Instead of like, I don't know, call 311. That's crazy. And like that's what we're dealing with, when we're dealing with, the systems or these places and stuff like that. We're dealing with a lot of that.
Thank you.
Yes.
Yeah. Thank you. Thank you. Member Wong, you have your hand raised? You might be on mute, Member Wong.
Yes. Sorry. Thank you, Chair. And thank you, Member Patterson, Co-Chair, because I think what you're speaking of is, I think that we've been going back and forth a lot about the mapping. And I think, I said it before, is about the listing that we have, the directory that we have. It's phenomenal that, what we have, the resources out there. But I think to Member Patterson's point is how we can actually look at something and say, this is what it serves, what it has, what is the purpose, versus, yes, I know that, okay, let's just say, center ABC, and then you have the number, but then yet there's no kind of like at least minimal what does the center serve, and I think that is so important. And I cannot concur more with Member Patterson's point about that access. And to you too, Chair, it is the accessibility of these programs and the services that are out there and that are existing and that are working.
Yeah.
Thank you.
Yeah, then you added that are existing and that are working. That's a whole nother thing. But we're gonna drive Mrs. James to gray hair in a moment if we don't move forward. So, Miss James, please.
Thank you. Thank you. And so so this is the first section, and that's just the big, oh, Miss, yeah, Member Lipton, you're muted. You're muted. I can't hear you.
Make this very quick. When you go through the various roles here, and much of it relates to the IWG has done this, has done that. It doesn't get into the working groups that have specifically been working on the staffing and on the metrics and on the mapping. And I think you ought to go back and look to see how these fit in and include those efforts so that when someone's reading this, it will look like the IWG has been doing stuff beyond what's actually listed here.
Yeah. And so, Member Lipton, just to repeat again, staffing, mapping, and you mentioned one other?
Staffing, mapping, metrics.
Metrics.
I'm not sure what else. You probably have to go back and look to see what other working groups we've had
Yeah.
that are,
Yeah, I think that's
that are
really important.
unrelated to recommendations for the various domains.
Yep. Yep. That's an important role of advisor that you've played.
Yeah.
Thank you.
Okay.
Thank you so much. Ms. James, are you, was that clear? Are you
Yes,
ready to move
that
on?
is clear. So we have a couple of additions that we'll make, including what we talked about, what Member Hammer talked about is making this, and what Member Lipton said, which is all about this role of advisor, is kind of making that clear. And I just wanted to note Vice Chair Patterson's point, I think, relates to the section on what's coming next. That kind of future thinking stuff is where he's going with that bigger picture strategy of access and mapping and things we've been talking about. So we'll get to that in just a little bit. So thank you both and all. So that after we go through the roles, then we go through every one of the sections, the street crisis response team, the Office of Coordinated Care, et cetera. And just an orientation, if you haven't had a chance to look through it, it gives you a brief of the recommendation progress. It gives you a summarized review of the initial recommendations, highlights on progress towards those recommendations, and then what remains to be addressed. As you go through the different domains that have been designed, here's the OCC, we'll come back to that. There's yellow in there we need to address. New beds and facilities. It gets a little bit less because these are newer. Every one of these becomes a little bit newer. So when we get down to some of the like crisis stabilization and TAY, we haven't had a return visit from DPH to address these recommendations. And with Mental Health Service Center, there are no recommendations specific to the program yet. You've been advising, but not the specific program recommendations. So that's why they look a little different. I did want to go back to the issue, and Ash, I think I just kind of elbowed into your area. You've been working on this. Did you want to go through the Office of Coordinated Care, or would you like me to continue?
Go for it, Jen.
Okay, thank you. Apologize if I took over. All right, so Office of Coordinated Care, these yellow highlights is a comment that was offered by Member Gonzalez. She is not here. But she wanted to offer this as a point of conversation between the IWG and DPH, and that is that the initial recommendations are represented as care coordinators, connectors, those kinds of language. That's what drives these recommendations. However, the highlights from the progress on the recommendation, there's mention of case management expansion, care management. So the difference between what the IWG was suggesting about coordination versus management is a question that she had.
She doesn't have a question about that. All she has a question about, and there's not really a question, it's just for her, she'd like to see that these are defined, like what the difference is between care coordination, case management, and care management. Those three, she's wondering if that's something that other IWG members would like to see included on the report. But the highlights of progress are like what the DPH team came back with, and it looks like what they addressed was that it is a lot of case management work that they're working on, maybe not so much care coordination. But I don't think she had a question there. I think her question was to other members and yeah, test work in the report if we feel like y'all would agree that you'd like some of these three defined in the report. Care coordination, case management, and care management.
Member Salinas?
Well, I did not participate in this work group, right, because of the conflict of interest. But I think I don't think that in their recommendations they really define these things. So I mean, she brings up a good point about this.
Yeah.
I guess if we're commenting as we go along, I know I did not write to but I do have a comment about the skirt. But so when we're done with this, maybe we'll go back super quick.
So hearing that defining these are important either, and it may be, we'll work with DPH on providing that definition a little bit more. Any other thoughts about Member Gonzalez's?
Yeah, and who knows if DPH's definition is the same as the folks that worked on this recommendation, because some of the, like, Kara is no longer here. I think it was like, I can't remember, Vika, I remember it was Vika, Kara, I'm not sure who else. So hopefully those are consistent with what the work group, that particular discussion group's definition were. Well, they didn't define, so maybe we need DPH to define what that would mean, and because for how it actually practically works.
Member Salinas, I consulted with Heather on your comment before the meeting, and she had to hop off for another meeting, but I just want to acknowledge that you've hit on I think a difficulty that we see as well, that the way we might define it internally is not necessarily the way it's defined externally, and we want to make sure that those terms are commonly understood when we're talking about this work. Heather's having a lot of active discussions about this internally herself, about what we should define each of these as and where these should live, and just asked for the opportunity to come back to you with a little bit more. She'd like to give it a little bit more attention and time. So I don't know if those will get inserted in this report given the timeline that you guys are on, but she, I think, is very much, her thoughts are in the same place and would like to come back to you with a more thoughtful response. So stay tuned on that.
Yeah. Thanks, Valerie. Yeah. So we'll make note that that's something to be, we have that what remains to be done. It's like that will be part of what remains to be done, is to come to better definition of these things.
And we'll go back to Member Gonzalez to let her know specifically how DPH plans to address this.
Thank you. And
Members, yeah.
I was just going to say, Member Salinas, is that a new hand?
Well, just in terms of the skirt, I think I was just looking at, at the initial recommendations, and I'm just want to maybe a clarification from how something reads here, that I think it's a little bit of a, I guess, and I guess it was an attempt to synthesize what folks were saying, but I think as it reads can be easily misconstrued. So I'm looking at 3A, for instance, even in situations where there are weapons or perceived threats involved. And I think that in those discussions, what members were bringing up is that folks that are homeless carry things that could be perceived as weapons. I mean, it's one thing if someone is, wildly swinging around a pipe versus you're homeless, so you carry pocket knives, right? You can look at the case of Luis Gongora Pat, who had a pocket knife on his belt and therefore was shot to death by the police, right? Homeless people have these things. It's not that we have any intent to use them in this context. They need them for living on the street. And those things frequently get construed as weapons, as do how people interpret who is a threat, right? Because someone's homeless, because someone is a Black man. And those were the things within that I would say in 3A and 3C that we were intending to bring up, and with the weaponization of 911 calls by people, who hold, whether really consciously or unconsciously, racist, very conceptions of what are threats that are steeped in racism. And so I think that with these, the way these are summarized, because if I were looking at this, and I'd be like, well, of course we're not going to send, a social worker and an EMS 6 person into a dangerous situation where someone's wielding a weapon, but that's not what we were saying. But this is how this could easily be interpreted.
Yeah.
So that's just something I wanted to bring up, where how this is summarized doesn't capture the intent of what we were saying.
Yeah. So 3A and 3C, we can go back. I have the original language on the screen. We can go back to that and make some adjustments to make sure that, like, we just cut words out and kind of tried to include some of the key components of it. And I hear what you're saying, Member Salinas, is that by doing that, we missed some of that context that's important. So we will put that back in. Thank you.
I just want to confirm, though, Member Salinas, as you see the original recommendations here, does that original recommendation of 3A, where the sentence begins, even in situations where there are weapons or perceived threats involved, the continuation of that sentence would you recommend be placed back in, that there is still need for mediation to de-escalate the crisis? Because this was the original set of recommendations.
Yeah, I think I need to, I can think about it further. Thank you for bringing those up. I think I wrote those. I have them somewhere. I need to, yes, it will get us closer, and I need to think about it. Is that okay?
Yeah. Yep. Thank you. We'll come back to you, and we may, Member Salinas, if some of the original recommendations didn't quite capture some of that nuance that you're talking about, we can always go back and bring those back to the IWG for consideration. Thank you. Any other comments on any of the domains that you provided recommendations for over the last 2 years? Street crisis, we went through Office of Coordinated Care. Is there anything on new beds and facilities or mental health service center?
Okay. Not seeing any hands.
I do just want to, the other, IWG member who did comment on this report before today, Member Lipton, thanks so much. Just wanted to note the changes that, just, some notes that he recommended that we place in the report. So Jen, you can move just to those 2 places where there are notes that just communicate why there are not those 2 other columns for TAE and Crisis Stabilization Unit, as well as Mental Health Service Center. Because we have only for TAE and for Crisis Stabilization Unit provided initial sets of recommendations. DPH has not come back to address on these initial sets. Yeah. And then for Mental Health Service Center, there have not been an initial set of recommendations provided by y'all yet.
Yeah, Ash, I think my comment was more focused on the timing, and that since there are not a response, what the timetable is, but there will be a response. I think under the Mental Health Service Center, that's been addressed by when they're going to begin the planning process on the next phase. But crisis stabilization, the recommendations were done 7 months ago. And I'm not sure I have a good handle. I'm not sure anybody else has a good handle of where we are in the process.
Yeah. And
I think there should be something in here on price stabilization. TAE, we only made those recommendations about 3 or 4 months ago, that there should be something in here that generally would indicate when it was expected that there would be a response, or at least when the department projects that's going to have these recommendations implemented.
Yeah, thank you so much, Member Lipton. We do have our calendars that we present at the end of each meeting that show when different departments have their next scheduled updates. I don't know if we do have the Crisis Stabilization Unit or TAE department heads scheduled update on our calendar, but if so, yeah, Jen, if you have that familiarity, if not, DPH, whoever is on the line, can provide when they intend to come back.
Can we get back to you? We are putting together the calendar for next year as we speak. So we will have that, and they will be returning because they try to return every 6 months to be able to give these recommendation updates. And so we're due for one.
Yeah, I'm not sure this is necessarily germane, but it would sure be nice to know what the current timetable is.
Yeah.
To when DPH is looking to implement the CSU, or at best implement the TAE, recognizing that estimates are estimates, and presumably it will be off by about 6 to 18 months. But at least we got to have some type of something about where we are in terms of progress and what the implementation dates are expected.
Thank you, Member Lipton. Member Hammer.
Oh, there. Sorry about that.
Yeah, quick question. The CBO salary analysis, and when we make recommendations in response to that, that's not included in this because it's not a explicit, it's not a domain, or should it be included?
Yeah. We didn't include it here, but I think that goes back to someone, don't remember, apologies, who said like in that first of role of advisor is being sure to mention those roles. Oh, it was Member Lipton. It's being sure to note those advisory roles
that are not part of the domain.
That are not part of the domains. Member Hammer, are you thinking that we need to get more explicit and list out those recommendations as well?
I mean, I would want to hear from the group, but I think if we're gonna make recommendations based on that, then I would imagine that it should be in the implementation.
Okay.
And if not this year, I mean, not this year, I don't think.
Yeah, I really
future
appreciate,
years.
I just want to hold, like, I really appreciate all your members, like, reflections today. We have been working on this report since November. I just highly recommend that if you do have some of these really critical recommendations, that you bring this forward to us earlier on in the development of this report. Come to the discussion group, attend those, because in addition to the future state recommendation, that section of the report was actually not intended, like initially intended to be part of this. And beautifully, these discussion group members who attended were like, this needs to be there. And so that's why that's now there. So I just want to like remind folks that we have a process that we've been following really beautifully in a collaborative way, and just want to name like intention and care in participating and providing these really important reflections earlier on. But really appreciate it.
Got it. That makes sense. And I would just say for future reports we could consider.
Thank you.
Member Field.
I think Ash's point's really good, but I think maybe there's a communication a problem here with working groups and recommendations and the annual report. Like for instance, I was in the working group looking over this, but I was recused from both the crisis stabilization discussion and the TAE one. So I think Member Lipton's recommendation, which is why are we sitting here months later without recommendations on that, should be in this report. And maybe nobody going over the drafts of this was aware that we were going to be moving these two things forward without a definite timeline. So, I mean, I think it's important that we should have a stated expectation from the department based on their workload and their time frame for when these recommendations will be responded to. But I wouldn't have known we hadn't gotten that because I wasn't in those discussions.
Yeah. It highlights the importance of putting together that calendar for the future, for the next year, so we can kind of.
And I think that I know we had this conversation prior to this meeting back in November with the recommendations, um, which is what I'm having a hard time really operationalizing in my mind because, and frankly, this gets to Ms. Sadka's point that unless we have participation in the working groups, going into a new model of having a retreat and doing all of this work, we actually we need participation both in this group, but then we also need participation in the working groups in order to make this happen. And so I'm finding myself getting confused. As Member Lipton was saying, well, we need to have these people back and da 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 da. And I'm like, well, that's not actually what we said we wanted. We didn't say we wanted ongoing sort of reports. That's what I heard people saying they don't want any more of. We want to follow more streams. So I find myself, this is not to debate this or parse it out here. I think what I'm really trying to say is I think we're in an interesting place where I'm confused at how we're going about doing what we're doing. And that's where I'm finding myself. So I just want to name that because I think what to Member Lipton's point, I think what we were doing was trying to make sure that we were getting report backs and we were kind of moving forward and we had these streams that we were following. That's what we were doing. But now I think you all propose that we do something different. But I'm confused about that now if you're still saying we need to go back to the other way. So I find myself thinking, like, what are we're at this pivotal moment of where are we moving? And also we're going to be at a point where we're going to be thinking about leadership and chair and vice chair and because it's that time. And so, I'm trying to think through for myself, what's the best use of myself and my time? Do I actually even know what people want? And so I just want to make sure that I'm clear on where we are as we're looking at all these recommendations. We're looking at where we want to move forward. And then also we always have these agendas that we're trying to get through. So then that also muddies the water a bit for these longer discussions that I think we actually need to have. And so I'm kind of pressing pause for a moment in the agenda to actually ask people, like, what is the best, most effective use of this 3 or 4 hours that we have once a month? Is it to go back and get these reports? Is it to actually follow some kind of bigger thread? Is it to finalize these recommendations? Is it that we actually need to all commit to saying, hey, we're going to read this no matter what, and give feedback no matter what by this date so that we're all part of this process? So I think the problem that I have with the smaller discussion groups is that there's basically, half of this group that is able to attend or less at any one given time because we're all very busy in our other lives and we have big commitments. So I never doubt that anyone has love and passion for this work that's even bothering to participate in these 4-hour meetings. So let me just be very clear. I just know that we're all pulled at different parts from different places. So I would love to just pause us for like a quick 5 minutes and just ask people, what is it that we want to be doing? And just if we can just each take a turn. Are we wanting to go back and getting updates on our recommendations, going back and getting the through line? Or are we really wanting to have more deep dive conversations about the full spectrum and full scope? And are those mutually exclusive? And if not, also, we want to invite you to participate in the agenda setting meetings. We meet 4 times. We meet every Monday before every month, pretty much. So, if people want to participate in those meetings, to also make sure that we're following through with, what this group wants, because I find myself not clear on what the group wants. And for me, I don't believe that I'm the one that can say what has to happen. It has to come from you all. So if we can take a moment for that and just popcorn it. And I think Member Fields, maybe I'll start with you because I know you you've thought about this a lot, or Member Lipton, you both have been working on this and Member Wong made the recommendation. So, and then we can go from there.
Okay, well, quickly, and I think part 2 of this report, when we're looking at the future, addresses some of that. I think you've absolutely pegged what the dilemma has been for us. Things started before we started meeting. So we're in 3 stages here. So there are things by necessity alluded to in the legislation. The department, to their credit, was not waiting for us to meet. They got started on them. So we weren't involved in any preliminary discussions about the assumptions behind those groups. And I think we would have had some different takes on some of it if it had been a broader discussion, but I don't fault the department on that one at all. We need to do it. Then we got into the very specific recommendations of elements of a new system, additional services in the legislation. So we were looking for a way to be involved in that process. And I think we learned in the process, it hasn't necessarily been the best way to use us in terms of exactly what you said, Chair Lasser. But we did do some things, and people put effort into those recommendations. So I think, in spite of the fact that I'm at least think we should take a more systemic view, more open discussion about where we're heading after these specific elements are sort of tied down. It's fair to tie those up. There's 14 recommendations, and I think we should close the book on that because a lot of people did put work into it. And that was the methodology we were using for a while, which was very frustrating to me. I imagine even to the department in some sense. So I think they all fit together. I think we're looking at the future now and saying, there aren't 8 more elements that we need to talk about and just be sitting and listening to a report. We need to talk about what the elements of a successful behavioral health system in the city are now and get past this sort of specific work. So that's how I'm viewing it. Our next step is very important in terms of how we define ourselves.
Thank you so much. Member Lipton or Member Wong, do you want one of you all?
Yeah, I'll try to be very quick. I think Steve said it very, very well. My comments were not about the domains that we do not have responses, was less about when we're going to get responses. It was more about when are we going to get the services that these domains are called for. And so I wasn't suggesting that we need to, hone in on when we get the responses on the domains. It's like, okay, when is there going to be a crisis stabilization unit? When is there going to be a TAE? When is that going to be implemented? The same thing goes true with the Mental Health Service Center. We got 3 major components of MHSSF that are still in the planning stages. And that's what my primary concern was. And I think, as Steve indicated, our focus ought to be more broad in terms of the system, as opposed to spending as much time as we have on some of the details of some of these things, and that on some of these programs. So that's kind of where I'm at.
Thank you so much. Member Wong.
Thank you, Chair. I think at this point, I think I get frustrated, and then I feel like I have to go back and then I have to ask questions. And I think part of it is, I think we really focus on a lot on the programs. And I really want to start, I think it's kind of correlated to what Member Lipton was talking about is the timing. But it's like, okay, we have all these things. How do we coordinate so that the care is starting to work? It's wonderful. I love the data. I appreciate the hard work because I know that everybody's going to put in a lot of work into it. But here we are, we have, all these programs, all these services. How do we now start linking together so that we can start helping what we're supposed to be doing with the mental health SF, implementing, right? And then the other thing is, I really appreciate these little discussion groups. However, I think when we do these discussion groups, there's only several and I think you touched upon it, Chair, that there's only several perspectives, right? Yes, we bring it back to the bigger group. However, when we do bring it back to the IWG, then of course, then there are some other perspective that ties in, and that's not to say that and to Ashlyn's point, it's not like we don't contemplate on the notes and all the other nuances of the progress, but it's just things come up, and I think other members probably reading some of the perspective of just the mini group, and then we say, oh wow, well, okay, this kind of triggered me to think about certain things, and that's why certain things come up too, not because you know we're not paying attention or we're not looking at the report, but it just it's a difficult process with a lot of restrictions and limitations, I have to say. Yeah, because of the Browns Act, because we're meeting virtually, not in person, and it is a very difficult process and frustrating as well. So
Thank you so much, Member Wong. Next on my screen, I see Member McGuigan. Would you mind chiming in?
Yeah, so I apologize. I haven't been jumping into the the sidebar groups, and that's something I really want to get going next year. So I need to do a better job of carving out the time to jump in there. I think I can bring some value in terms of kind of working with some of the termed out foster youth at my previous job, and then just giving some experience into what I see day to day, through the fire department and responding to people and kind of more real life situations. And I really would like to, is if we can, start meeting in person or doing sidebar groups, I would love to, possibly, I know I brought this up before about, kind of doing some site visits, just so everybody has an idea of, how things are there. And I think if you can get some real life perspective on, kind of seeing what's working well and what's not, I think that would help. So
Okay.
I appreciate everybody's hard work. And I'm sorry I haven't been contributing as much as I should, but I'm looking forward to really getting in there and kind of getting my hands a little more dirty next year.
Okay, thanks, Member McGuigan, and thanks for bringing back up the site visits as well. Thank you so much. Member Hammer is next on my screen.
Sorry, Chair, that's an old hand.
Oh, no, just to have you chime in.
Oh, let me, I wasn't ready for you to call on me, so
that's
let me
okay.
just collect my thoughts.
That's okay. Can I go to Vice Chair Patterson? Or to Member Salinas if you're not ready yet, Vice Chair?
I mean, there's a lot, and I think that we do need to work on our processes, and I think it will mean that has to be a lot more participation by everybody. That's the thing. I think I for one have felt at times that I'm doing tremendously much more work than lots of folks on the IWG. I know you do a tremendous amount of work behind the scenes that I think we don't really realize, and at the same time, though, it's daunting, right? Because when you have your months off, you have your months off, and it's like, but I have been thinking, like OCO, how they're structured, and maybe we can look at that. But they put in a lot more time. They do put in a lot more time. But it is a structure that maybe we can look at and see if that could work for us. Yeah.
That's Our Children's Our Home?
Our City, Our Homes?
Our City, Our Home, yeah. And what is do they meet weekly?
Well, as I understand, they're running everything. The committee members run everything, right? Harder and Company isn't actually, they have working groups that are meeting, they have separate working groups that are meeting monthly, and they're putting everything together, right? They decide the agendas, like they decided their work plan, they decided their agenda. They've got their separate work groups that are meeting, every month, plus the big meeting, right? So they're doing a lot of side work. So, and that's, I don't know that I would have that kind of capacity though, right? So maybe some sort of a hybrid in there. But yeah, it's because it's a lot more accountability. And so I think it is a question about accountability, right? And how are we going to create the structures and the mechanism for that and maybe certain folks wouldn't do so much of the heavy lifting if it was more evenly spread. So that is, so that it could be a benefit, right?
Mm-hmm. Thank you, Member Salinas. Member Hammer?
There's so much to say. I mean, I agree that 4 or 5 hours a month is not enough to review everything that we would need to review and meet and make recommendations and make sure our recommendations are written to reflect our thoughts. I think, and yet completely agree with what's been said, that it's hard to imagine members of the IWG giving more than that amount of time each month, as invested as we all are in the successful implementation of Mental Health San Francisco. I would love to figure out some sort of streamlined way that we can get more sort of maybe digested materials to read, and with like focused asks about what sorts of feedback is most useful, and deadlines and stuff. But I agree with everybody that this is important, and that we need to figure out a more efficient way to do this, because I don't think anybody has a lot more time to give than like what Member Salinas, Chair Lasar are giving already, and others as well.
Thank you, Member Hammer. Vice Chair Patterson? Did we lose you? Vice Chair Patterson? Jamil?
You're muted, Jamil, if that helps.
I'm not, yeah, maybe he's not there for right now. We'll see if we can get him back. But thank you so much, everyone. That gives us a really good, I know I absconded with the with the agenda, Ms. James. I just felt that we needed to do that. And it brought up things very clearly for me. So about what we need to do. So I imagine we will noodle. And we want to invite folks to maybe our next agenda setting meeting. So let's the Harder and the city team and I connect about what date that is that we set the agenda and to set the process, and invite folks to that who are interested, if that's okay with everyone. And then if you can't attend, just sending any additional thoughts. But I think this gives us very clear direction. So I really want to appreciate everyone's feedback. Thank you. Without further ado, can we jump back in? I think we have people here waiting to present. Is that where we should go?
We do, and we had I just want to confirm, Chair Lasar. So we had kind of went stepwise through the December report. We still have that last section on future opportunities, which is very much a part of what we just all discussed. Yes. Is there anything that is there anything in there that we need to go a little bit further into, or are we comfortable with submitting these opportunities that we've put in the report as is, knowing that we're going to have to come back to this and really reconsider that based on people's capacity, et cetera? Okay, that's what you're saying. Okay. And are there any other comments from the members about that final section, which is the future opportunities?
And again, thank y'all for the feedback on the rest of the report. Jen and I have made note of some of those changes that are doable within this time frame between now and the 27th due date. So we will address and incorporate those recommended edits, specifically, within the background section, to Member Lipton's point, and for those listed recommendations of the additional groups that y'all participated in, we may or may not be able to incorporate those given the time frame. But to your point, Member Hammer, we shall definitely, think about incorporating those in any future reports.
Jen or Ash, real quickly, I just want to say you guys have done a hell of a job. You have taken the suggestions, and in some cases, in my case, some of my ramblings, but for all members, taking ideas from everybody and trying to distill it into a report. I think you've just done a heck of a job. And if we were all in the same room, we'd probably want to give you a round of applause. But thank you very much.
Yeah.
Well, I think we can give virtual applause, and we can do the. Thank you. Yes, here. Yes. Applause. Big love, big applause, big appreciation. Points well taken, and your passion is well noted. So thank you. And also, just let me say, this is a very challenging time of the year, just in general for most people. So just want to acknowledge that your grace under pressure for both of you so much. So really appreciate you both, and Oksana and the rest of the team as well. Thank you. So are we at discussion item number 7 then?
We have one last thing to do about this, which actually does relate. Ash, if you could share the screen again. The conversation we just had was one that needs a lot more depth and considerations, like how are we going to do this differently? What is optimal for everyone? What can you take on? What can we do a better job of supporting you in? We had talked to there has been talk about a retreat. And we did some discussion about what a retreat might look like. And we didn't want to assume that everybody wanted to do a retreat, to the point like that we're saying that there's only so much time that folks have to give. So the retreat would really be about answering these bigger questions about optimally positioning the IWG to do its best possible work, what kind of supports you need, what kind of, how you want to organize yourselves, all of those kinds of things. And what we wanted to do was poll you all to see if you wanted to do a retreat. So when we're doing this poll, we put down 5 bullets so that we can have a common definition of what this retreat is. So for the retreat, when we say, do you want to do a retreat? The retreat will be focused generally on these opportunities in the December report, how you want to organize yourself, all of those kinds of things. It will be in person is the second thing. The third, it'll be no more than 4 hours. We're thinking it's in addition to a standing meeting. So there will be 1 month where there's actually a potential of 8 hours, just of meeting time, let alone any preparation or work that you might have to co-develop it. And it's going to be a public meeting. It will have to be agendized as a public meeting. So it will be open to the public. Are there any questions about the definition that we're using? Because we would like to poll you to get your interest in this. So before we go to the poll, is there any discussion or amendments to how we're defining what this retreat would be?
So can I get a clarification, Jen? So is this retreat, is it like an ongoing thing in addition to the 4 hours monthly, or is this a one-time thing?
It's a one-time thing.
Oh, I see.
It's
And
one
please
time.
correct us if it's wrong, right? Y'all were the ones that, had recommended that there be a retreat, your discussion group members. So if that's consistent with what y'all had recommended, then yeah.
And I think the recommendation, and you see that in the wording of poll 2 on your screen, the recommendation of poll number 2 is that it be in March. So the group had initially suggested it be in January, but with the surges that are happening, we were advised that we might push it back to March just to be able to be thoughtful about the public health crises that are underway. Any other questions?
I just have a question for clarification. In poll number 1, should DPH co-develop this? Regardless of the answer to poll number 1, Harder would still support developing it,
Yes.
right?
Yeah, we would be here to help you to the level that you want to be help. If you want to do it by yourself, we can support you that, or we can take, more a
Okay.
stronger facilitative role. So we can negotiate.
And we would need to, talk through our team whether or not we can come up to do an in-person, but that would be the hope.
Yeah.
We could as a small team.
Any other questions?
Looks like we're good.
All right. So Ash, you want to do the poll? All right, the poll has been posted. And there's, Ash, it looks like there's 2 and 4 are repeats. Is that right? Should IWG have a March retreat, and should IWG have a March retreat?
I'm not sure. I created 2 questions. Maybe the webinar,
3
I
and
can't see it
4.
on my end how it's
Yeah.
shown.
Yep, we got both questions repeated.
Yeah.
Oh, yeah.
Yeah,
Right.
1 and 3 are also repeated. Yeah.
Yeah. So just answer question 1 and 2. Do not answer question 3 and 4. Those are a repeat. So just questions 1 and 2.
I'm sorry, Jen. I exited out the poll. How do I get back in there?
Get back into the meeting or get back into the poll?
To the poll. The poll.
I don't think you can. I think we'll include yours when it's submitted. Because otherwise I'd have to close the poll and start it again for everybody.
Okay. All right.
So it looks like we do have 7 members who've answered both questions 1 and 2, and then we'll incorporate yours as the 8th member, Member Wong, verbally. So I'm going to close the poll. Still waiting to close it. I'm now going to show poll results. Again, please look at questions 1 and 2 answers. I'm not sure on my end if you'll see the repeated questions and their results, but please just look at 1 and 2. Are you on your end? Again, I can't see it on my end, seeing the results of 1 and 2.
Yeah, we see that.
Cool. So I am seeing, and please verbally include your responses, Member Wong.
Number 1, I would say no, and number 2, I would say yes.
All right. So for question number 1, which is if we were to have a retreat, would y'all like DPH to co-develop this? We have 5 no's and 3 yeses. So majority would say that no, you would like to not co-develop this with DPH. And then for question 2, we have 8 out of 8 members say that they would like to have a retreat in March. This would be an in-person. It wouldn't be more than 4 hours. It would be in addition to your standing meeting in March, which is, as it always is, the 4th Tuesday of the month, and that this would be a public meeting. And yeah, sounds like that is what people would like.
All right, on the public comment then.
Okay, so we have a response. I imagine that we would also invite folks to plan the meeting with us as well. So, or whoever is chairing and vice chairing at that point. So let's go ahead and assume that we will be inviting folks to participate in the planning.
Yeah, and I would maybe even encourage the members who had brainstormed this retreat, maybe y'all leading the communication as a result to getting other members to join you in this conversation. That's one that I would recommend.
Thank you, Ashlyn. All right, can we roll on to public comment? Okay, Ms. Taika, please.
So those who'd like to provide public comment, you call 415-655-0001, access code 2488316-2188, and then the webinar password for today, 1234. Then you'll press pound and you'll then dial *3 to line up to speak. I did see that there is one caller in the queue. I'm going to unmute them. I've sent a request to the host to unmute. Again, we are waiting on the host to unmute, and then now you may begin your comment. Caller, you may begin your comment. You have been unmuted. Please begin your comment. You have 3 minutes.
Can you hear me?
Yes.
Can you hear me? Oh, okay.
Yes.
Sorry. Well, I just wanted to say I actually did send an email asking some questions which didn't get addressed. I sent it on the November 18th. So I'm just gonna make it a statement, I guess. But it came up earlier as far as, having no access to this information about all these new groups. So I'm assuming that the Office of Coordinated Care would be responsible for creating a usable directory of mental health services available to citywide providers and maybe even the public. Honestly, it would take one dedicated clerk, maybe a month, to create a list that's online. I'd like to hear what the Office of Coordinated Care, how they're coordinating this. Also, regarding acute psych beds and the crisis care and everything, I feel like San Francisco General is really not stepping up to the plate. I know they've had a lot of input, maybe back behind the scenes and stuff, but I kind of feel, I work for DPH and the 7th floor is always full. And for people that have been actively self-medicating for a while on the streets, they may not have the wherewithal to stay in a program that they can just leave from in order to actually get an accurate psych diagnosis. I'd like to know what San Francisco is doing, the 7th floor. When you're on crack and meth, I mean, you can't be expected to just kick it, even if you really, really, really want to. So there's that. And I think that's it. But I guess as a longtime employee at a chronically understaffed facility, I would like to know if the 760 full-time staff, full-time positions includes the DPH, because that came up in the last meeting, but I guess you actually answered that. But maybe you could let us know how people respond when an email is sent, since we can't ask questions on, in the meeting. That's all. Thank you.
Thank you. And thank you for sending your email. Controller's office, let us know if you have anything to address there regarding email communication and responses.
Sure. Yes, the best email to use is that mentalhealthsf sfgov.org email. That's the one that's the official email, so that's the one that's preferred to use, and we'll forward any requests to DPH.
Sounds like they did send an email on the 18th. So we will do our due diligence. It sounds like Controller's Office to forward that request. Any other
Yes, we'll
things?
forward it to the appropriate leads.
Any other reflections, Chair Lassar, before we move on to the next item?
No, thank you. Thank you, caller. I appreciate your sort of want to use your participation and your presence. Thank you. So shall we move on to I believe discussion item number 7?
Yes.
Okay. So reminder of the mental health SF domains. We are going to be. Oh wait, there we are. Okay. We are going to be talking about the Mental Health Services Center options analysis. Is this right? Is this what I'm supposed to be talking about? And this includes a crosswalk and a benchmarking of the services in May. This doesn't sound right, proposed in June. So it sounds like this is some old text. So I'm just going to say welcome, Dr. Pading, and team, and have you take it away, and then I'll get to whatever correct language I'm supposed to have. Thank you, and welcome, Dr. Pading. Also, a quick reminder that we are stopping Jen at we need to stop by 12:55. Is that what it is? So we can do the ending and end at 1. Thank you so much and welcome.
Good afternoon, everybody. Could we go to the top of this slide set, Jen? Is that okay? Is there one more? Oh, okay. Yeah, next slide then. All right. So first of all, I personally want to thank you for all the hard work. I've been on commissions. I've worked with commissions. I know how hard it is to be on a commission, particularly when the charge that you have is so complicated as it is. So, you know, if I, on behalf of our staff, can give you some appreciation, I'd like to express that now as you take on the big charge of oversight that you've just discussed. Hopefully give this a quick issue today just to give you an update. This is really a process update. There's not a whole lot to report except we have not been before you on the Mental Health San Francisco Mental Health Service Center since August when the controller had been presenting. I've been asked to lead the development of the programs for the Mental Health Service Center because of my prior experience with developing programs, both in and out of DPH, as well as with my partner, Young Joan Kim. So we'll be coming to you with regular Mental Health Service Center updates. Next slide, please. I want to present this slide to you to talk about where I believe, and this is my vision of it. This is not a vision that's overly complicated. So I want to just keep this at a really schematic level, where the Mental Health Service Center sits. I like to use a hotel model where our street crisis response teams are the Uber and the taxis that bring you in to the front desk, which we hope will be the service center to connect you to your room and place you in the right level of care, of which the new beds and facilities are trying to create as many rooms as we can on that committee. And all along, we have these wonderful, I'm not sure what to call, bellhops, bell people, persons that escort you to your rooms, but the Office of Coordinated Care. And so I want to place the service center in the middle, as it should have two hands on this as bridging function to get you from here to there in whatever mode that you're needing. Next slide, please. As you recall, and again, I'm going to repeat what the controller shared with you so I can link to their presentation to now. These are the 6 elements that the Mental Health Service Center is required to have: assessment of needs, a pharmacy, transportation, psychiatric assessment, diagnosis, care, case management, and treatment. That's actually a large bucket. It's larger than it looks. Mental health urgent care and drug sobering center. Next slide, please. This is also what the controller said were your options. They gave you an option with some price ranges and some strengths and barriers of the options, as well as equity capacity to meet equity requirements or goals with these options. Option number one was one big mega site that had all those 6 elements: a crisis center, a pharmacy, a sobering center, and there was a price there of what 32 to 53 million, which is under your 100 million that you previously discussed. Then the other option was something more distributed, where you have multiple locations, including an urgent care center. And the option 3 was something virtual, like they have in New York City, an expanded call center that connected you to services. Next slide, please. After your discussion, you weighed in and you preferred option number 1 and you preferred option number 2. I don't know if that was an and or an or, but those were your preferences. And most importantly, you said nah or no to the virtual center. On that basis, our team went back and said, you know, what can we do? What have we built? What are the other things that we can bring together into sort of to build a service center? And we were actually also told to build a service center with in the constraints of shrinking Prop C funds, given that we may go into a temporary recession or cutback in tax revenue. And so what we would like to propose to you, or are proposing or updating you on, is our intent would be to build something that is a combination of option 1 and 2. And the reasons are rather obvious. One is we've already built a drug sobering center. And 2, we've already are establishing well moving along a crisis stabilization unit, which people were asking. We are looking for early 2024 for the crisis stabilization unit. That it makes sense that some other functions that we already have, an access center, a pharmacy, a buprenorphine clinic, coordinated care, outreach and assessment teams, could be combined in something, that bridge clinic, that front door that gets you from here to there. Next slide, please. And we imagine that these centers could be stacked up in a way that really makes sense as a cohesive set of integrated services. Your sobering center, for example, has the lowest intensity of services, which are mostly hospitality care. People can be brought there by street crisis, receive food and showers and a place to rest. They would be linked as needed to alcohol sobering if they had alcohol withdrawal management or residential care or shelter placements or emergency stabilization units. On the high end, we also are looking at the crisis center stabilization unit, which would have a high level of nursing care for people in high level need. It also could be a service to street crisis and emergency medical services, and a very high intensity of services, which could then provide pre-treatment for people needing to go to withdrawal management or stepping directly into acute diversion units or respite like Hummingbird, or if they need higher level of care, could be assessed for emergency care services. So that leaves a middle ground of ambulatory care services, which I believe a mental health single site kind of bridge clinic that could accept street crisis, could work with the outreach teams to walk people in, could serve people that are not currently housed or linked, to link them to outpatient mental health, enhanced care management under CalAIM, Door Urgent Care, Hummingbird, Respite, or our residential services, the new Maria X Martinez Urgent Care Clinic, formerly Tom Waddell, or transitional supportive housing, or actually possibly an on-site food pharmacy. That's what I heard. There might be the possibility of linking up with food services that could be in such a building. So these are a conception that we're thinking that, you know, building on the model presented by the controller, we could bring together the kinds of services that we've discussed with you, combining existing services, and do it within footprints that the city has already begun to develop. Next slide, please. So the next steps would be to try to bring you regular updates as we think through these things. We need to do an additional dive into next year. As you know, Prop C revenues will probably be less given that the tax, is it a tax base, or the amount of taxes that we collect in the city will be lower. And we'll have to reevaluate our programs to see about scope for all of them. My understanding is it won't mean a decrease in services of anything we establish, but certainly we have to look at new programmings living within the box. And then we hope to refine what we've given you, which is really a gross cut based on the controller's report, to come back with further refinements of the scope of the one-stop center. And we'll be giving you updates as well on sobering and the crisis stabilization unit, as we promised, at regular intervals as well. So that's the update. We have 12:46, 9 minutes for discussion. So I will turn that over to Chair Lasser. And again, thank you, Chair, for all the work that you do.
Oh, no, thank you. It's all love. It's all for the people. So thank you so much for your report. I'm looking for hands for any questions or feedback for Dr. Pading or the team. Yes, please, Member Salinas.
Okay, I guess I'm confused. So you are suggesting a standalone clinic where you're going to do linkage? Is that?
Yeah, we would combine existing functions, both a pharmacy, which is already situated at 1380 Howard. We have access center. We have some substance use services in the OBIT clinic, and our Office of Coordinated Care. We would try to bring in a way that we could both provide assessments, linkages, services, and serve that middle ground function that I showed you, that bringing people in, holding their hand, getting to the next place of where their destiny and where they need to be going.
So the standalone center, and you would move some of the things that are currently at 1380, like OBIC and the pharmacy, to this new site.
We don't have any new site at this point. We were just looking at the functions that we could co-locate and do it in a way that builds on what we have. And then we would try to fill in gaps. But we already have a crisis stabilization. We have a drug sobering. We have these units that we put together. We would go back to the legislation and figure out what it is that we need. I think it's probably something with like a brief treatment of some sort, maybe like a couple of days where people are, we brought them in, they're waiting to get hooked up, some bridge services. That's what I imagine we'll be fleshing out in the next. But we don't have a site at this point. We are looking for different sites, but there's been nothing that's been identified at this point.
So some of the functions of TAP as well would go.
Yes, TAP Plus. I think we could do and improve on kind of what we have. I think that was one of the visions of the service center, that somehow what we have is not necessarily meeting all the needs. So yes, we would want to stretch beyond that and build on TAP and other things.
Thank you. Any other questions? I'm not seeing any hands yet, Dr. Pading. Okay, it looks like that was hopefully painless to you. And we appreciate your updates. I think for me, the pharmacy connection with other services is really super important. My only question about that would be the hours of the pharmacy. I don't think you mentioned that, did you?
Oh yeah, I always try to forget the hours. So the TAP Center is already open to 7 and will go to weekends. The pharmacy hours are already extended. Actually, if you go back 2 slides, I think we have the pharmacy hours.
Were they there? Sorry.
They're 7 days a week already. If you go back to maybe it's slide 5, and then keep going. Next one. There we go. Pharmacy is 9 to 6:30 Monday through Friday, and Wednesdays 9 to 4. So we're there already, and then we got to tweak the other services and fit them in a
Yeah, I think
box.
Wednesday or a weekend? Do you mean
That's a weekend.
9 to 4?
Weekend.
Not Wednesday. Yeah.
No,
weekend.
well, it is Wednesday, but 9 to 6:30, and then weekends 9 to
I think
4.
the weekends aren't on there. I think that's what's missing.
No, it says pharmacy. It
I
says
see pharmacy Monday through Friday, 9 to 6, and
But
then it says, oh,
Dr.
WE,
P said
yeah.
Wednesday 9 to 4, but he meant weekend 9 to 4.
Yeah,
Okay,
should it
thank
be?
you.
I probably should have put an SS, right? Is that how you do
Yeah,
it?
whatever, something, but yes, thank
Yeah,
you.
it's weekend 9 to 4.
Yeah, because I think that to Member Fields' point, I always remember him sharing the point of the person on a Friday night needing their meds. So this doesn't get into the Friday night part, but it still gets into next Saturday morning, 9 o'clock. You can start to get
Yes,
meds.
yes,
So
and yes.
I think that that's absolutely crucial. In trying to keep folks stable that are or get medication if they need it. So
Yeah.
thank you so
And
much.
the BHAC Center, we have weekends 8 to 5. That's anticipated. That's not quite yet. That's happening spring. But that is the plan. Is the weekends will be opening. They're Monday through Friday to 7, and then weekends soon come. They're hiring right now. That's so I need to put that. I should have put a star on that one.
Okay. Well, thank you for clarifying. I'm not seeing any other hands. It is 12:52. 9.
Oh, I'm getting BHAC time starts in January. Oh, that's good.
Great.
Somebody just sent me a message.
Hey, thank you for listening and answering. So I'm not seeing any other questions or hands. I will, as I said, don't have a real slide deck. So please tell me where we are. Are we at
We're at public comment from mental health.
Okay, please, Ms. Sadka.
Yes, so those who'd like to provide comment on this item 415-655-0001, access code 2488-316-2188, then you would use a webinar password 1234, and then you'd press pound and then you dial *3. See if there are any callers. Currently no one yet, but I will wait. See if anyone joins the queue. Since there are no callers in the queue, I'm going to close public comment and we will go to our last discussion item.
Actually, I think there's one more, before we go to that, there's one more public discussion, or public feedback that we need to do that's about anything.
Public comment for any other matter not within the jurisdiction of, or like not, yeah, any other matter. 415-655-0001, access code 2488-316-2188, webinar password 1234, then you press pound and then dial *3. So this is just for any other matter that is still within the jurisdiction of the committee, but just not on this agenda today. All right, since there are no callers in the queue, I'm going to close public comment and we're going to go to the end notes of our meeting.
So this is just a note that in January, we're going to vote on a chair and a co-chair for 2023. In the preparation for the IWG meeting, we sent out kind of a notice to have, if anyone is interested in throwing their hat in the ring, get it? Hat in the ring. Do you see the hat in the ring on the diagram? Anyway, if you're interested in throwing your hat in the ring for this, we were going to have you give a brief statement given timing. We're just going to ask that you please, if you are interested in serving as a chair or a vice chair for 2023, that you submit your statements to us and we'll collate them and bring them back to the January meeting. So again, that'll go out with our post communication. If you have that prepared, you can just email it over to us right now, and then we will vote in January.
And just to be clear, there's no time limit, so we can re-up if we want to
Yes.
participate, we can. If we decide we don't, then yeah, all of that. But it's going to be a vote, basically, right?
Yes, correct.
Okay. Thank you.
Thank you, Chair. All right, next slide, Ash. Some housekeeping notes. There is going to be a continuation of the mapping discussion. We're still giving a date for that in January, but that is going to be the first meeting with DPH. There was a lot of talk about getting on the same page with what mapping meant. And so this will be an ongoing conversation that probably will continue for a while. So there is if anyone would like to join that conversation, you don't need to be part of a formal group to join, but we will put out that time as soon as we have it. And we encourage you to attend, as we've been discussing today. January 24th is our next meeting from 9 to 1. We are going to be getting our 2023 calendar together where we can share that with you. To many of your points is kind of knowing the cadence of when things are coming back and how you can connect it to the bigger picture. We do anticipate that in January, we're going to be talking to either OCC generally or to a case management team expansion to that topic. And we're going to be identifying community engagement, what community engagement would be helpful for the IWG in your role as advisors. So we will be doing those two things for sure in January. And Chair, I believe that that's all of our content for the meeting, so I'll turn it back over to you.
Great. Thank you so much. Just wanted to say thank you again to everyone for all your time and your energy, your passion, your input. And your life force, your spirit, because I know this all takes a lot. So thank you. And thank you to all the presenters today, to the mayor's office, the controller's office, to Harder and Company, to DPH. Thank you. It's been an incredible year. And so I'm looking forward to 2023. So wishing you all a very happy holiday, solstice, whatever you celebrate. And we will see you in January. So make a motion to adjourn.
Move.
Second.
Great. So that was Member Fields and Member Lipton. Did I get
Yeah.
the voices right?
Yeah.
Okay. Thank you.
Thank you all.
Thank you.